big. Thank you, Chris. Thanks for calling.
Hello, everybody. Welcome to the Children's Committee. Thank you for being here today. We're just going to I'll do some quick housekeeping, and then I'm going to send it over to my esteemed co-chair. This meeting is the status of the mental health management in Connecticut, the challenges and the opportunities. We thank you all so much for being here today. And just keep in mind, please, that mask rules do apply in the building. And when you are speaking, you may have your mask off, but when you are not speaking, we ask that you keep it on. There are some members of the committee via Zoom who will be involved. And we just thank you all for being here and for your support of kids. And to you, Senator.
Thank you, Representative Lenihan. Good morning, everyone. Thank you for everyone who is here this morning, virtually and physically. We appreciate you being here. We have a pretty ambitious agenda today. Hopefully, by the end of our conversation, we will understand what is the current status and also learn about the good work our agencies and the state of Connecticut is doing to make sure that our children are protected and taken care of at all different levels of care that they need, especially for the mental health challenges that we have. And with that, I just want to share a little bit about how we are planning to do our entire informational hearing. And we will move things around a little bit based on some schedules. If you look at the agendas, we have 3 panels. That is the panels that are focused on the various levels of care that our children need in our state. And of course, if you look at the entire situation, there is care that they require at various levels. And we want to make sure that we address all those levels and then see what needs to be done on an immediate term, what needs to be done intermediately, and then what are the long-term things that are needed. So the good news is that we have very important stakeholders throughout our conversation today who will be able to weigh in and share their experience, but also share their perspective on solutions. And with respect to Q&A, because a lot of things are interrelated, you will probably get answers throughout the conversations today. So instead of having a question and answer session after every panel or after every speaker, we will just have clarifying questions from the chairs, but we will have open the questions towards the end of our panels and the conversations by our state leaders as well. So that's something I wanted to say. I saw my ranking chair, Senator Henry Martin, for a second. Senator Henry Martin, do you want to say a couple of words too?
Talked about that.
Thank you. Senator Arnott. I'm anxious to hear what everyone has to say. Just want to thank everybody for coming today to sharing your knowledge to assist us in what we may have to consider doing legislatively, if anything at all. But thank you from me anyway. Thank you.
Perfect. Thank you so much, Senator Martin. So the next, I just wanted to move things around a little bit. I'm excited to invite Commissioner Dr. Manisha Jutani, who's the Commissioner for Department of Public Health. Dr. Jutani has a very busy schedule today, and because we had changed some of the schedule on our part, that actually had a conflict. So she will be able to speak now and give the DPH perspective and her role that she's been playing in the last many weeks to try and address this. So welcome, Dr. Jutani and Commissioner Jutani.
Thank you very much. Thank you for the invitation here today. And I'm glad to have this opportunity to speak with all of you. I want you to know first and foremost that I've been on this job since September 20th. And since day one, this is an urgent crisis that I've learned about and been collaborating with Commissioners Gifford, Durantes, and many others in state government to be able to try to address this issue, which is affecting our children very acutely. And we know that it is also affecting adults. That is an even larger question that needs to be addressed, but we're here to talk about our kids today. So a few things that I want you to know first and foremost is that, as I said, we've been very aware of the issues that have been facing emergency rooms with a lot of children sitting in the emergency room. And we know that this is something that has been in the press as well. What I want you to know is that we have been working with our partners at the Connecticut Hospital Association, and we have been working specifically in sort of an incident command type setup where we have been helping to situate patients that are in that emergency room. And I'll let my other partners speak to that more so, since that is more in their territory than mine. But I want you to know that as DPH, we have been involved in that piece as well, because the question of whether patients need to be diverted from one hospital to another is something that rests in the authority of DPH. And so we've been in constant discussions about that. We recognize that one hospital's problem just becomes another hospital's problem, and really it's a capacity issue. And there are other people who are more expert at that than me who can address some of those issues. But I do want you to know that we have been at the table for these discussions to be able to figure out when and if a hospital needs to go on diversion and how that might look in order to be able to help best care for our kids. Now, on the issue of capacity, like I said, I'm going to let others speak to the capacity issue, but where we do have some contributions is on licensing, and specifically whether it be facilities or whether it be practitioners. And what I would say there is that, OHS is involved with certificate of need. There are other things that need to happen before licensing comes to DPH. What is the need of a community? What is the need at a hospital? And so there are steps that need to happen before they come to DPH, but we are very aware of these issues and very much understand the need to be able to provide increased capacity, are very committed to being at the table and continue to remain at the table when it comes to these issues. When it comes to issues of licensing, we have already been streamlining and fast forwarding as much as possible any person who comes within our system to be able to get them licensed as quickly as possible. There are issues that have come up about compacts. There's a group that is specifically looking at this. And so there's a group that's specifically looking at what is going to be happening across state boundaries. And can a practitioner that's worked in one state versus another state be able to work in the state of Connecticut? What I want you to know is that I'm very committed to this issue as well, and will remain at the table as is necessary and as is identified if there are practitioners that we need to be able to get on board to be able to help meet a staffing issue, and we will address those as they come up. Specifically on the topic of Public Act 21-9, I just want to raise an issue there because this is something that often comes to my desk in these last several days, which is that many people are under the impression that since telemedicine was allowed in that act, and that there is a line that says that the public health commissioner can authorize people to do telemedicine out of state. I just want to clarify that I actually do not have that authority just blanket with the way that the act is, the way it was written, with the executive order that expired at the end of July. There are certain professions where I have the ability to waive Connecticut state licensure for 60 days, and that's it. This issue will arise again within 60 days. So for example, for physicians, there are certain professions such as a speech pathologist where I don't even have that authority. It does not exist in the authority the way Public Act 21-9 was written. It was written that these things could happen, but it didn't give me the authority to do it. So I just want people to understand that even though this is in place and 21-9 allowed for a lot of other things to occur, it did not allow me to just do that. So I do get complaints from constituents and hospitals outside of Connecticut. For people, physicians who are outside of Connecticut, they can get a Connecticut license and practice telemedicine. That would be fine. But what they want to do is be able to maintain their New York license or other state license and provide telemedicine to our patients in Connecticut. At the moment, the way things stand, that is not something that I can just do. So I just raise this to you to say I'm very aware of this issue. I want our people in the state of Connecticut to have access to behavioral health in the way that they need in all ages, whether it be adult or childhood. And I have heard what your issues are. I am very aware of it. I am very committed to these issues. I'm here to be a partner in helping solve these things, but I am limited in the number of things that I can do individually. And I just want to say that I'm here as a partner, very aware of our children's issues, and hope to remain in that way to be able to help solve the problems going forward.
Thank you so much, Commissioner. And you will find the Children's Committee, all the legislators across the board. This is not a political issue. This is an issue. It's about our children, about their well-being. So you will find partners in each and every legislator as well. I think what we are hoping at some point to do is to identify what needs to be done on the legislative side to empower you to be able to make sure that our children get care throughout the entire spectrum of care that they need. And when we truly appreciate your words today, I do want to just clarify a question. It's a clarifying question for the CON and for behavioral health and mental health issues. I had put a legislation in that because it was an emergency that we should not have a CON for that, but that the legislation did not go anywhere. I think the timing is an issue for a child that is going to, and the family that's waiting in the emergency department, waiting for the CON committee to wait and have the lawyers and people work on the specifics. It's going to be months at best based on the historical data. And the child cannot wait for months to be able to get the CON and then the licensure and the extension of beds. So this is an emergency. So I just want to share that thought with you and then see if you would have some thoughts on how to address that part.
Yes, absolutely. And we all recognize that. And, I've been working with Commissioners Gifford and Durantis, and there have been a lot of things that they have done to be able to address these issues with existing capacity. And, we are hopeful that in the days ahead, there will be certain things that might be available. And the hospitals have been working together specifically on that regard. So, there are things that, like you said, are within our control, but every partner has been contributing what they can to this issue. Everybody recognizes that we can't just wait around for some of those things. So what can be done within the existing structure? I'll let Commissioners Gifford and Durantes talk about that a little bit more as well. But I want you to know that we're very well aware of that, and whatever can be done within our capacity. And the hospitals have all been at the table trying to do the same. trying to do with, whatever is existing right now.
Thank you so much. And I know my colleague has a question as well.
Thank you very much, Senator. Commissioner, welcome. This is obviously, since you're so new, this is your first time in front of our committee. We thank you for being here. Because you're new in the position, you're probably new to me, so I will introduce myself very briefly to you. Not only am I co-chair of this committee, I'm also a mama bear. I'm a mama bear who has a child with a mental health condition. So I look at this through a very different lens, and that's where my questioning is going to be with you today. You had talked about speeding up licensure, and you recognize that that is an issue. However, the licensure that you're talking about is about facility licensure, correct?
No, I specifically meant about practitioner licensure also. So
Okay.
so for example, I know that during this pandemic, and Dr. Gifford might be able to speak more to this, but I know that even practitioner licensure, this is before I came to DPH, was being streamlined specifically during the pandemic as well.
Right. So let me give you a little bit of background of what we're seeing on the ground, because since you're new in the position, you might not be aware of the problem in its entirety. For instance, when I went to my pediatrician for information on a mental health professional for my adolescent child almost 2 years ago, I was given a list of 6 names. All 6 names never called me back. They don't have the room. I was given a list of another 4 names. Of those 4, only 2 called me back. The 2 that called me back called me to tell me they don't have room. They're not accepting any more patients. That's a lot of people to have to call. Additionally, just last week, I received an email from a practitioner in my district who has been trying to be able to take her test, a licensed clinical social worker, I believe. She has 30 families that she was seeing through her clinicals. Once clinicals ended, she's not allowed to see those families anymore. Those are 30 families who are probably going to their pediatrician and getting 6 names and not getting any callbacks, and then getting 4 more names, and 2 of them only call back. Same thing is happening to everybody. My concern is that when you're talking about speeding up licensure, I have tried to contact people from your department 3 times, separate people, and I haven't gotten any word back. This could be as very simple as extending the ability for these practitioners who have ended their clinicals to be able to see their patients while they are still being overseen by a licensed practitioner. So we're talking about continuity of care for families who have already been able to find someone, have established a relationship, and then they're going to be kicked out of that relationship. These practitioners or graduates who would like to become licensed practitioners are having trouble scheduling their test. And they're unable to get a hold of people at DPH. They're unable to schedule the test. They're unable to even get a date for the test. So when we talk about truly needing practitioners, we have to really talk about the fact that there are practitioners out there ready and able to see families and currently seeing families who are then taken offline because we're unable to schedule tests. This, to me, is the quickest and easiest way to allow children to start to heal. Is there anything that we can do to move this forward ASAP?
I'm glad you raised this issue. Now that I'm aware of it, I will look into it further, figure out what the obstacles are to that, research it, and understand what the challenges might be. And I will let you know.
That is music to my ears. Thank you. And I will
can't
give you
promise
every
more than that, because I
Right.
will tell you that I learn every day what I am statutorily allowed to do and not allowed to do. But I can tell you that I will look into it.
Absolutely. Thank you. And I will make sure that you have every telephone number and email and address and anything you can to get a hold of me to work that. And I do have just one last question. You were talking about telehealth. I believe telehealth has a great place. I believe it was extremely important during the shutdown. However, when it comes to children and mental health, I am firmly in the camp that telehealth just doesn't cut it. So I agree that it needs to be there. I agree it needs to be an option, but I think that it is extremely important that we don't fall back on, we have telehealth, it will be okay. Children need to connect. They spent months in isolation. They didn't have another human to connect with. In this regard, when we're talking about children, telehealth just won't work. And one last thing, Senator, if you will, I do want to mention that this that I did put in legislation last year in order to have an incentive program to attract new psychiatrists to the area, require them to accept Husky and private insurance in order to get those benefits. I will be putting that forward again, and I'm hoping to have your support. I will send that legislation to your office, and hopefully we can work collaboratively.
Thank you. I look forward to reviewing that. I also want to just let you know, I too am a mama bear. I too have felt your struggles and felt your pains and know about not receiving phone calls back. I know this space at an intimate level as well. So this is important to me personally. I understand exactly where you're coming from. I will be a partner with you to do what I can. There are things I'm not going to be able to do, but then we can work together to figure out how to still move it forward.
Thank you so much. And I can say absolutely I feel okay speaking for everyone on this committee when I say we are committed to working with you and not against you to overcome these challenges and really get to the heart of the issue and do what's best for our kids. So thank you very much. Thank you, Senator.
Thank you so much. And I think the bottom line is when it comes to children, we are all on the same page. We just have to figure out how to make it work. Commissioner, just wanted to leave you with a couple of thoughts with the emergency declaration and the executive powers of the governor. We may have an opportunity to take care of the immediate needs while we look at the solution. So I'm just going to leave you with that thought. And I know from a long-term care perspective, there was one of the bills, I just have that here, 2135-35, which basically looked at your department chairing a committee to look at the solutions going forward and report to the legislature around February of next year. But that group has not met yet. So I just want you to be aware that you'll have a lot of things happening as you take on this big and important responsibility. And we are very glad that you're here. And thank you so much for your time.
Thank you for alerting me to that. And I look forward to addressing that as well.
Thank you.
Okay, thank you.
All right, with that, we are going to move on to our panel one, which is a conversation about the status of emergency department utilization, hospital beds, partial hospitalization program, and the intensive outpatient program. Again, this is a part of the conversation we want to have because this is part of what brought attention to the immediate needs, but I know that the needs are at all different levels. I have four individuals who will be speaking on this on the panel. We have Howard Savronsky, who's the Chief Behavioral Health Officer for CCMC. Thank you again for being here, Mr. Howard. And Patricia Raymer, who is the Hartford Health Care President for Behavioral Health Network. Thank you so much for being here. And I understand Jason Melia is here too. Or he's probably online, along with Dr. Frank Fortunati, who is the medical director for Yale Psychiatric Hospital, and Jason Melia is the clinical program director for Yale New Haven Children's Hospital Emergency Department. So with that, Mr. Savronsky, you can start, and we'll go ahead.
Thank you, Senator Anwar and Representative Linehan for this opportunity. I want to start by just underscoring that this is not a problem that's limited to emergency rooms or hospitals. What we're talking about is a throughput issue and the breakdown in our entire system of care, that we need to look at this holistically. So with that in mind, let me just sort of frame out the experience we're having at Connecticut Children's and talk about some of the challenges we're facing and offer some suggestions in terms of opportunities going forward. Connecticut Children, as you know, is primarily a children's medical center that provides high quality medical care and mental health emergency care through our emergency room. But that emergency room is designed, as you probably know, in most hospitals, to treat the most serious of conditions. Our emergency room has been the recipient of children coming in for both medical and behavioral health conditions. Those behavioral health conditions are oftentimes on a range of acuity, and often we're seeing more and more kids coming in at the lower acuity range that we would consider non-emergency. So one of the challenges we face is how to best care and provide the care for those kids that really don't need to be in an emergency room, but need some kind of urgent, rapid, immediate care for their mental health problems. The hospital has experienced, as along with probably most hospitals around the state, a growing number of children who whose discharge has been delayed because of the lack of resources at higher levels of care. We're certainly experiencing that on an acute level, both in our emergency room and in our medical surgical units, where children who come in for medical care get medically cleared, so their medical conditions are managed, but their need for additional psychiatric care demands that they stay until we can find a higher level of care for them to move on to. And the lack of those, lack of access to those beds oftentimes results in them staying longer in the hospital than they need to. We often talk about beds sort of generally and generically about inpatient beds, but I just want to list that these kids are waiting for a wide range of resources. Some are there for inpatient psychiatric beds. Some of them are waiting for residential PRTF, which I think you'll hear about in other speakers. But there's a whole other group of children that have intellectual disabilities, who are on the autism spectrum, who have severe eating disorders, who need specialized care that is oftentimes not available in your general psychiatric units. We also have children from time to time that need intermediate levels of care that in this state is only provided at the state-operated hospital at Solnet. We were able to develop a model of care many years ago to provide a bridge for children who are able to be discharged from the emergency room, but who are awaiting placement in a more permanent mental health resource. And oftentimes it's that gap that results in recidivism back into the emergency room. And we're very proud of what we've done in that model. But one of the challenges we face is a sustainable financial reimbursement model that could help us to maintain that program and grow that program. And the last issue that we're facing is probably one that we're all facing, has to do with workforce. And the challenges that we face along with all of our partners in being able to recruit and retain competent, trained staff to provide the kind of quality care we need to our children and families. So in terms of our opportunities, we would like to recommend that, number one, we look at how we can expand our emergency mobile psychiatric service. The EMPS program is a vital service to the state and critical when we are looking at the flow of children into our emergency room in our hospitals. We know for a fact that EMPS can provide a very positive, be very positive in being able to divert children from hospitals, but also for those children that do wind up in our emergency room, EMPS has been very effective in helping us to more rapidly discharge back to the community. We would also recommend that we find ways of streamlining admission processes to many of our community-based programs so kids can get more rapidly discharged from hospitals. Again, we would like to have new financial models considered that could provide a more sustainable financial basis for programs such as ours and many of those that you'll be hearing about today. We're also recommending that the state adopt or provide the funding to develop a rapid assessment program where we could provide an alternative to families, to schools, and to physicians who have a child who's in need of mental health care, but who do not require emergency room level of care, where they can go and get an assessment and get referred to an appropriate provider to meet those children's specific clinical and emotional needs. And lastly, we would urge all of us to do what we can to find ways of incentivizing mental health professionals, clinical and non-clinical, who can come and work in our programs, our agencies, and our hospitals to provide the highest level, highest quality of care to the children and families that we serve. Thank you.
Thank you so much. Thank you for your words. I've been taking notes on each and every aspect. Ms. Remer, if you would.
I want to echo the commissioner's comments that this is a pandemic for both children and adults, but we're here to talk about adults. I also want to mention that there is a mechanism that I'm aware of through the Department of Mental Health and Addiction Services where you can waive the CON process. So if a provider came to DEMAS, and I'm aware of this as former commissioner, and there was a need, the DEMAS was authorized to waive the need for a CON. So for example, we recently we are starting a new substance use disorder program. I went to DEMAS and requested a waiver. The waiver was accepted, and so we did not have to go through the CON process. So I think it's worth looking into that. I think overcrowding at all of our IDs across the state is happening. We know both CCMC and Yale, as the two children's hospitals, are being hit the hardest. While there have been a few lulls, there tends to be between 20 to 40 children in the EDs at these two hospitals. But we are also seeing more children in our adult behavioral health units across Hartford healthcare system. So for example, during the period of October 8th and October 25th, we admitted 85 children to our inpatient system. 35 of those patients were from CCMC, but 50 were from HHC EDs. This indicates that more children are arriving at all of our emergency departments. And the issue with having children in adult emergency departments, adult behavioral health units, is that we think that that is not a good place for them to be. So we are constantly triaging between the children's hospital and our own hospitals to ensure that those kids are not sitting in adult ABUs. The IOL, the Institute of Living, contracts with CCMC to provide psychiatric coverage for the ED. During this crisis, we've added additional psychiatrists between 2 and 3 a day, which takes away from our ability to provide other services. And we are now receiving daily reports from CCMC's ED about who needs inpatient care so that we can more adequately try to triage those patients. Since the Incident Command Center that CHA put together, we have admitted 75 to 80% of the children that need inpatient care from CCMC. Hartford Healthcare has over 50% of the beds for children and adolescents in the system. We have 29 beds at the IOL, 26 beds at Natchog Hospital in Mansfield, and 16 beds at on our Westport campus at St. Vincent's. That's a total of 71 beds. But as you just heard, and as we are seeing in all healthcare settings, staffing is a critical issue. And at this point, we are actually struggling to keep our units staffed so that we can care for the children appropriately. So for example, while we have 16 beds licensed at St. Vincent's today, we are staffed for 15. The staffing issues, by the way, are not only needing nurses and mental health workers, but as Representative Lanahan commented, we are also struggling with filling clinical positions. And I would echo the need for the testing because we are experiencing the same thing. The other opportunity I do believe we have is to use more individuals with lived experience, more peer support individuals. We have a Recovery Leadership Academy where we train individuals in recovery to work in the system. And I know that the leadership of that academy has met with DCF, and they are very interested in partnering with us. We use those peer supports in our adult emergency rooms, and they are extremely effective. These would need to be young adults, not adolescents. But again, having adolescents listen to a young adult who has been through the system would be extremely helpful. Throughput is a significant issue. Length of stay on an inpatient unit should be no more than 3 to 5 days. Being on an inpatient unit for kids is highly traumatizing, unfortunately. And so we really have a problem with throughput. We don't have enough community resources. We don't have the programs that we need to discharge kids to, as Howard mentioned the PRTFs, SOLNet. Now we understand DCF is facing the exact same staffing issues that we are having. So, we're all in very similar position. But when an adolescent or a child is not able to be discharged and has a long length of stay, we're tying up a bed that we could turn over 3 or 4 times, decreasing the amount of kids that are stuck in EDs. As you know, and I think you mentioned this yesterday, Representative, there is a program that is funded through DCF, the Access Program, which I think has been highly successful. One of our recommendations was that we could extend this to an e-consult model so that individual pediatricians could reach out to psychiatrists via email and get a very quick real-time response on what the recommendations were. I will echo your comments, Representative, on telehealth. We have found that it is extremely effective for adults, and we were actually quite surprised, given how plugged in most kids are, that the adolescents did not like it. They want to be there, they want to be in person, they want to have those relationships. Also, in adult behavioral health at Hartford Healthcare, we've been able to put in a primary care behavioral health model where we have clinicians in our primary care offices with psychiatric backup to provide care for individuals that may not need the highest level of care, that can be served through primary care. This is definitely an opportunity to replicate that in pediatricians' offices. And the PHP and IOP, I would say that Rushford, Natchog, and IOL work together to try and ensure that we can get individuals into partial hospital programs and IOP programs without any waiting. So we work closely together, but we do see, for example, that if you've had a child in an IOL program, you may want them to go back to that IOL program. So what we have developed is a STEP program, short-term enhanced programming, clinic, as a bridge for children and adolescents that are in need of a higher level of care. There were 16 appointments scheduled this week for that service. However, that too is pulling from other programs, which can create problems in the other programs. We would support the idea of urgent care centers in the community. We think that these can be a solution. However, we are concerned about the time it would take to get those in place, but again, a longer term solution. So I'm going to stop there. Happy to take any questions.
Thank you so much. Thank you. We'll have our next speaker. That would be a virtual speaker, Jason Malia, who's a clinical program director, Yale New Haven Children's Hospital Emergency Department. Jason.
Thank you very much. I'm going to actually let Dr. Fortunati start. We just have a few slides to guide our conversation, and appreciate the time here.
Thank you, Jason, and thank you, Senator Anwar and Representative Linehan. I'm the Deputy Chair of Psychiatry for Yale New Haven Health System and a child and adolescent psychiatrist. And Representative Linehan, your comments really hit home. I know for many years I had a private practice, and I understand exactly what you're describing, how hard it is to get folks into care and how busy everyone is. I can say that just as far as the hospitals are concerned, as Jason is about to get into this, just a few comments. Just a few years ago, Yale New Haven Health, we prided ourselves on not having kids stay in the emergency department overnight. We were able to move kids from our emergency departments to an appropriate setting, and if it was inpatient, to inpatient, without having them stay overnight. And on the throughput issue, we are no longer able to do that because of volume and because of the need. And even with outpatient, we have difficulty sometimes getting adolescents into outpatient programs. And so we end up continuing to do them through our IOP program, and we created a step down program as well. Earlier, the commissioner referenced the hospitals working together. Through that work, I know that, for instance, as of yesterday morning, throughout the state, there were in the state, there were 66 children and adolescents, age 17 and younger, in an emergency department throughout the state. and 39 of them were assessed as needing admission. In our own system this morning, there's 17 kids in our emergency departments through Yale New Haven Health, and 12 of them are assessed as needing admission. And so the need is real. And and Jason will go through some of our data. I think graphically it helps demonstrate how the need has changed so much over the past few years.
All right, thank you, Dr. Fortunati. Just to give a little framework and context, our health system and our children's hospital, overall, we see about 90,000 children a year. And of those 90,000, we see over 3,000 behavioral health patients through our emergency departments only. And that doesn't include any urgent cares. As Dr. Fortunati alluded to, we have inpatient capacity for children and adolescents at our health system. We have 40 beds dedicated to children and adolescents that are inpatient beds. We actually have 41 because we go over capacity on a daily basis to provide what's necessary. And what I'm going to get into is that having beds doesn't fix the problem. We have a challenge of getting people out of the beds that need to go back into the homes and their communities and be supported at home. And with that, we would increase our throughput. But without that, the number of beds you add does not change anything. We also partner with the Yale Child Study Center, and in our ambulatory realm and outpatient, together we see around 70,000 behavioral health visits per year. That includes some home visits and some integrated health visits within primary care offices. And overall, we're made up of 5 hospitals, 10 EDs, and we have many different ambulatory sites. I just want to put some context into 4 different challenges that we are really experiencing right now. The number of behavioral health patients that we see on a daily basis and hourly basis is increasing. I'll tell you right now, if we add up everyone that is in our inpatient, pediatric, and adolescent areas, our inpatient medical areas for behavioral health and our EDs, we have 70 children in our hospital for behavioral health needs. It's a humongous number, and I reflected with some of my colleagues yesterday. I started as a nurse in our emergency department in 2005, and many of them I still work with, and we talked about in almost a joking fashion, it was a hard day when we had 2 behavioral health patients in our ED, and now we run an average of 10 and up to 22 a day. So huge change over a very short period of time. Additionally, as Howard also alluded to, there is an insufficient workforce. We are very challenged in many realms, whether it be physicians in the outpatient practices or even social workers in our emergency department. Context of the emergency department is we're here to treat emergencies. We're very used to treating them quickly and providing some throughput. Behavioral health patients take significantly more resources to care for. At Yale New Haven, for every 1 behavioral health child, we would have treated 7 non-behavioral health patients, just in the amount of time it takes to go through assessments and disposition for those patients. So it's a significant amount of time for these behavioral health patients to be in our facilities, despite the amount that we have invested into making it a quick experience. And the patients are sicker. We use a variety of different tools to assess how sick behavioral health patients are, and it's been increasing. 40% of the children that come to our ED for behavioral health are here, and we consider them moderate to high risk for committing suicide. That's much higher than it had been in past years, where it was 20 to 30%. And it's a significant challenge to be able to handle this many children in our ED every day. Just to go an overview, I mentioned we have 40 beds. This is a look back across the past year of what our inpatient census has been at Yale New Haven for children. And you can see pretty much, I think, every single month we are over capacity, meaning that on any given day, many of these that are over the black line are waiting for a bed in an emergency department. So, today, right now, I have 10 patients in our ED waiting for a behavioral health bed, and a few of them have been waiting almost 3 days. And that's having a lot of inpatient capacity. But what we don't have is a lot of capacity to put them out into the community. We don't have the ability to hook them up to resources within a quick amount of time. And on average, it takes 7 to 10 days on a good week to get them connected to a resource in the community. And what that causes is patients to end up being admitted to inpatient, because we're not going to keep them in our ED. We're going to admit them to inpatient areas when they technically, in the best case scenario, don't need to be on an inpatient unit. The same aspect applies to the patients that are already in an inpatient unit. Many of these children that you see in the bar graph in some way, shape, or form, they don't need to be in an inpatient unit because their treatment is complete. As far as inpatient care is concerned, they could be back into the community, but it takes a significant amount of time to find them a place to go or resources to come into their house, just because everything is at capacity. Our referrals in ambulatory and outpatient areas for our own facilities are at an all-time high. Like we've referenced many times, we don't have the capacity to treat that many. In our ED, we've invested a lot into behavioral health. Due to the numbers that we see, we have a full-time psychiatrist. We have 5 days a week of behavioral health social worker coverage. And we have almost, on some days, we have five behavioral health social workers seeing the children in our ED. That is their only job, is to see behavioral health patients. It takes a significant amount of time. A full shift, an 8-hour shift for a social worker, they can see 2 patients, sometimes more, but many days it just takes a lot of time to connect them to the resources that they need to. I appreciate some of the comments on how many calls you need to make to get people connected. Our social workers, that is what they're doing on a daily basis, call after call to find someone to connect them to. We have weekend psychiatrist coverage, and we actually have invested in milieu counselors, which are very specific to behavioral health, and they provide a milieu and care to our pediatric patients in our ED. I just want to bring some attention to this. This is the amount of time we spend in our ED caring for behavioral health patients. This is since 2014. It's increased over 400%. This is due to a variety of factors, many of which is waits to get into outpatient facilities and waits to get into an inpatient facility. It's much more challenging, and when they're sicker, it takes a lot longer. The same applies exactly to what I referenced, which is the inpatient bed capacity. This is how long our patients end up waiting for inpatient beds. And you can see, like Dr. Fortunati had mentioned before, back 2014, 2017, even a couple years ago in 18, it was very, very seldom that we had somebody wait more than a couple hours to go to an inpatient psychiatric unit. And over the past few years, it has skyrocketed for the amount of time these patients have to stay in a small room, not always with a window, in our emergency department that's designed for people to stay for 3 hours, but they stay for 3 days. It is extremely challenging. Of the patients in our ED, this is where they go. I think it was referenced in the beginning, very few go to inpatient arenas, and probably even less than what we send could go. A majority end up in our treat and release facilities and in observation and end up going home after their stay in the ED. And lastly, I'm going to turn it back to Dr. Fortunati, but this is really what we recommend as what we can do now to significantly impact the throughput and impact all of our children's lives on a daily basis.
Thank you, Jason, and highlighting how often we're over census with our 40 or 41 beds dedicated to children and adolescents. Some of that is because we've several years ago created flexibility where we could put in older adolescents, age 16 or 17, on a unit that had young adults, 19, 20, 21-year-old. It's increasingly difficult to do that because, as Commissioner Juthani mentioned earlier, this is clearly a child mental health issue, but it's also an adult mental health issue. Today, I have 30 adults waiting for an inpatient bed, and we have a total of 118 beds, or roughly 98 or so are dedicated to adults. And so these things interact with each other in complex ways. Things that we would recommend is expanding emergency mobile psychiatric services. to expand what they're able to do and offer more bridging services. So for as an immediate solution, so that for adolescents or young or children who we feel don't need to be in the hospital, but clearly need to be seen more quickly and followed more closely until they're stabilized. Emergency mobile psychiatric services may be able to do that. Increase outpatient IOP services. A few years ago, the way to get into our adolescent IOP at Yale New Haven, which is hospital-based versus as opposed to a clinic or private practice, but the hospital-based program, it used to be 5 days. Now we're at 10 days to get in, and even from our own system, and because of capacity, it's over capacity. I appreciate what Representative Linehan said earlier about trying to attract more folks into mental health in the state of Connecticut. And I would emphasize that that's really at all levels, not just psychiatrists, but social workers, LCSWs, and psychologists as well. I would, I was just recently helping my son with a microeconomics class, and I was reminded about the elasticity of supply and those kinds of things. And it's really so closely tied to fee structures. I know our local mental health authority I'm involved with, they start folks who have a master's degree, and they start at $44,000, and that's about all that they can afford. So we're asking young folks to go into a field where their potential future from a standard of living is limited because reimbursement is so low. So many folks will start working for a clinic and then will leave and go into private practice and just take fee for service. And we need to retain our experienced folks in care. And part of that, it must involve looking at reimbursement so we can attract and retain folks who are talented and who are committed to working with our children. I think that's a must, and that would be a long-term solution, but I fear that things won't improve if we don't look at reimbursement. And we thank you very much for allowing us to speak to this.
Thank you so much, Jason. Thank you, Dr. Fortunati as well. And thank you, Howard and Pat. This is very helpful. I know we'll have a number of questions, but I think what I heard clearly is that what we're seeing in the emergency department is a symptom of a much more deeper problem. And the much more deeper problem is a throughput issue, which actually includes many issues within itself. And the workforce is part of that problem. And if we do not comprehensively address them, we will be having these conversations again and again and again. So thank you so much for that. With that, we'll move on to our, you want to move on to our second panel, which is, again, a very important part of our conversation, which is about psychiatric residential treatment facilities, PRTF, mobile crisis units, and intermediate level of care. So with that, I'll ask Hector Glenn, who is working with the Village, and Dr. Lane Taylor, who's the medical director at the Village, and Alice Forrester, Dr. Forrester, who is a chief executive officer for Clifford Beers, and Jeff Vanderplog, who is with University of Connecticut Health Center. Thank you so much for all of you coming in. And I think we can start with Dr. Taylor and Hector Glenn.
Good morning, and thank you. I think you're going to hear the same pattern of problems and solutions from most of the panelists. So the Village is a nonprofit located here in Hartford area. We serve over 20,000 individuals every year. We have a very large ECC, in which you guys described yesterday, with the rule of 2 and access, same-day access options. But what we really wanted to describe today was the highest level of care. So the most acute children really in the state, and there is not a huge capacity. We are one of 2 nonprofits that run PRTFs. It's us and the Children's Center of Hampton. And then DCF runs PRTF level of care as well. But between over the years, this level of care has lost beds. It is one of the more difficult levels of care to try to balance from a fiscal perspective. It is a sort of fee-for-service model in piece, and so you can never have excess capacity in order to really staff at a level that is appropriate. And it really does look at that throughput question. We are designed to do treatment within 4 months, which for children is a very long, long time. But when you're thinking about the chronicity and level of intensity of the problems and issues that are addressed in the family and these children, 4 months is a blink of an eye. And so, Dr. Taylor can describe the work that we do within the PRTF, but really understanding that families have a choice and they have to choose to come to the PRTF. And that is an important part. Choosing to have your child in someone else's care, even for 4 months, is a very difficult decision. And it's something we take very, very seriously. Dr. Taylor?
Thank you so much. My name is Dr. Lane Taylor. I am the medical director for the Village.
Would you
I'm-
press the button?
Oh,
So, yeah, there you go. Perfect.
Thank you. My name is Dr. Lane Taylor. I'm medical director for the Village. I am also one of the child psychiatrists that work with the kids in our PRTF, as well as other levels of care at the Village. A quick bit of background. I actually used to work at Yale New Haven Hospital on one of their inpatient units prior to taking this position. I've actually worked, I think, arguably on every level of care available in the state of Connecticut, including Solnit when I was a trainee. So, yeah, I think working in a PRTF and the experience of working with families at PRTF is really quite unique. It is not the same as a residential, even though it's called a psychiatric residential treatment facility. It is not the same as a residential. It is a relatively brief length of stay for children who have very intensive needs and families who have really intensive needs. And what has been observed and noticed is that the families are coming to us at a place of being overwhelmed already. So, parents are the experts in their kids, and we work with the families intensively to try to help them be able to meet the needs of their kids, as well as to understand how the entire family is impacted by a child who has severe mental illness. We do that in 4 to 6 months. When families come to us at a place of already being super overwhelmed, by the time they present to an inpatient unit, often those kids and those families have been through so much or trying to access so much and hadn't been able to, that they get to a place of burnout. And also, often what happens, and we have right now 4 kids in our PRTF whose families have said, I can't do this anymore, have actually said, we cannot take our children home. And what we need to be able to understand about this level of care is that there's so many layers that need to come before. It's an imperative and a really important level of care that needs to be in our state. It is unique. I've worked in other states where that wasn't an option. And so you would just have kids floundering and dying, really. But we need to be able to provide levels of care prior to, so that we can support the families. When they get to us, we can do the work. At Eagle House, we do really phenomenal work. We not only work with the kids, and we do individual therapy, medication management, but we have an entire team approach that is holistic. We do family work. We do psychoeducation to the families. We have a school, and we actually work with the schools to transition the children back into their schools. We work with the community, and we think about, when this kid goes back to their community, what other non-therapeutic services are needed? We work with DCF. We work with other state agencies that are involved in the child's care. That's intensive, wonderful work. And we need to be able to have the parents have the supports necessary, so that they don't feel like they have to make this horrific choice of, either I take my child back and feel unsafe, right? Or I have to say, no, thank you, I can't take care of my kid anymore. And so that's the place where we have increasingly got to. And I think that actually the numbers from Yale New Haven Hospital, I really appreciate Dr. Fortunati and Jason for presenting it in that way. Because when I was working at Yale, I saw that trend as an inpatient psychiatrist, and kids are presenting at a higher level of acuity, sicker, more depressed, more thoughts of suicide, more thoughts of wanting to hurt others because they're just so overwhelmed by their emotions and actually hurting people, right? So there needs to be an investment prior to, and all of what my colleagues have spoken to today about needing for access to integrated care, preventative levels of care where kids can actually be sort of seen or even understand their emotions before it gets too big, right? But also thinking about increasing access to intermediate levels of care, so that there is easier to get kids before they even need to get to the hospital. One of the pieces that needs to happen, though, is also coordination of access. There needs to be a way to be able to access understanding program slots that are available, so that there's not a need to like spend 2 hours on the phone calling provider after provider after provider. That's a thing. It's possible to do. So there's so many different levels that can happen prior to getting to PRTF. But also once we get to PRTF, we need to expand, and we talked about, Dr. Fortunati and Jason spoke about fee schedules. We need to really fund these levels of care at the right level. We have the workforce who is at the beginning of their training, taking care of our kids who are struggling the most. And by the time they're really at a place where they're saying, okay, yeah, I think I have a good handle on the kind of work I'm doing with kids, they say, well, I'm going to go and not be in a place where things are so acute, not have to be dealing with so many crises all the time. And then we have to start over again, right? And there's that lack of continuity that happens. And so I think being able to expand the payments so that we can retain and keep really excellent clinicians and psychiatrists and APRNs in the highest level of acuity places, we have to focus on that piece as well. Thank you.
Thank you so much. But before you guys go ahead, because the way I see this is that the two of you are the experts on the PRTF for us today, and actually arguably for the state at this time. And what are the three things that can be done to address the challenges at the PRTF?
For the PRTF level of care, it is one of the more complex. The issues of licensure and oversight, multiple agencies and pieces. It is one of the more heavily regulated levels of care. So at any given point, we have disability rights coming in to visit with the kids. We have DPH, we have DCF. So it is now a partnership, and we talk with the state agencies very often. And trying to provide safe care is difficult. We are dealing with highly acute children, but they're still children. And so how do you balance that safety and pieces? We recently, just erected a fence around our campus. Our campus is no more than 10 minutes away from here. It's located on Albany Avenue and Bloomfield Avenue, a very busy sort of intersection. And the issue of elopement or children trying to leave the campus because of some of the behaviors that Dr. Taylor were describing became so high that we had to spend almost $50,000 to erect the fence in order to help keep them safe. All those little investments, all those pieces, I think, the short-term solutions for us, is always about, we have old buildings. They're not ideal. Dr. Taylor, when she joined us from Yale, she said, you need more space. Children need space. And so all those areas, there is an investment that has to be done at this level of care. Is that the most important investment at this point? I'm not sure. I think you've heard the issues of throughput in other areas and pieces. PRTF is definitely part of the solution, but it's not the only part.
I think I can additionally add, I can additionally add that the idea of incentivizing workforce and specifically thinking about workforce at the higher levels where there are individuals who are having to work with kids who are dealing with aggression, who are dealing with really significant self-harm, that wears on you over time. And as an agency, we work to help our staff to feel supported through all of that. But the reality is that their pay is very low, as Dr. Fortunati explained. I mean, our direct care staff, we've recently increased their pay. COVID, realizing the acuity of the kids, we have invested in that, and they have the highest, I think, of the PRTS in the state. It's still not enough, right? If you're every day dealing with crisis every single day, what keeps you connected to this job, right? And so incentivizing people who have the education, who have the background, that are invested in wanting to work with these children, an idea of having legislation that would really support that commitment to children in Connecticut, and specifically thinking about more highly acute kids, is really key.
Thank you so much. Thank you.
The only other part that I would like to just mention, there's two pieces. Part of the issue with PRTFs is there are very specialized populations, and you heard, one of the speakers before talk about the issue of children with intellectual problems or deficiencies. That's a big issue. We do not do well with those kids. Mixing them with highly aggressive kids can be really problematic. And so every day as we're looking to do admissions, there are gaps for kids who we have not been able to solve. And in order to fix that throughput issue that you hear about, we do have to think about those specialized populations and how we deal with them. Stepping down from our PRTF, the village has a robust system of care, and also, really strong connections to partner agencies to do it. But we're finding, like, one example of unintended consequences or issues during COVID is we run programs called extended day treatments. It's a more generic function of an IOP or a PHP. The reason IOPs and PHPs are hard to manage is because transportation. How do you get a kid, to the IOP every day or every 3 days? How do you manage the school piece? Because they're still kids. And so within the extended day treatment model, they have transportation. Now, we can hire staff, but we can't get them certified to be able to do the transportation. We can't get the type of endorsements from DMV in shorter than 6 months. And so we have to hire staff, but we can't take kids in because we can't get those types of certifications. So, but all those little barriers in trying to expedite or get things through really do cause problems within not only the workforce, but the system.
Thank you, Dr. Forrester.
Thank you very much, Chair People and members of the Children's Committee for having me here. I'm the CEO of Clifford Beers Community Health Partners, and I'm very interested in talking about our current public health epidemic of mental health. We are an affiliate of nonprofit organizations that focus on the health and wellness of our communities. We're in Fairfield County, Norwalk, New Haven, 18 towns in the greater New Haven region. We serve well over 6,000 children and youth a year and offer an array of mono and bilingual services, including outpatient mental health, homeless youth services at our affiliated Youth Continuum, embedded in all of the schools in Norwalk and many of the schools in New Haven through our partnership with Mid-Fairfield Mental Health Clinic. We are deeply embedded in the community in New Haven, often offering a large array of mental health services, care coordination, embedded in New Haven Public Schools, mobile crisis, and we recently opened an autism intellectual disability center in Hamden, outpatient center in Hamden. Recently, Clifford Beers was approved by OEC to run 3 school readiness classrooms because of our new merger with Farnham Neighborhood House in Fairhaven, where we run basketball clinics, lifeguard training, and repairing 80 acres in Durham to open summer camp for kids. Added up into our community experiences with all our partners, we're well over 200 years of service to Connecticut. Why, do you ask, is Clifford Beers spread so thin? Why are we doing all of these things, merging and affiliating with our community partners? Why are we doing this? Well, with 200 years of experience in our community, we know that it's just not an hour of week or therapy or IOP that is actually the solution for many of the children and the youth we serve. We understand that we have to work with the whole family, that the issues generated in the children and the acute mental health issues that you're seeing are often attributed to chronic stress and trauma. And we also have to begin to understand the physical, mental, and social influencers of health, from diaper need for our little ones to transitional housing to rehousing after a crisis, shooting in their home, food distribution, community canvas after a traumatic event. We need to begin to look at mental health from a public health lens. Children's mental health has been declared a public health crisis, and so we have to address the problem with an eye towards prevention and intervention. And we need to spend a lot of time on looking at the kids in crisis now, but also, like Dr. Elaine said, really look at the kids we can prevent to going to the hospital. When we consider the youth held in the hospital emergency rooms right now, we are talking about, in the scope of things, a relatively small number of children, right, in acute need. We're talking 100, 200. I can promise you that there are many more youth in mental health crisis who are not accessing our emergency department, or who are doing it through alternative ways, on a stretcher because they've been shot in the community, or their families are there as a medical emergency because they have to use the ED as their primary care because they have no access to primary care during the business hours if they work third shift. As outpatient providers, we keep many children out of the emergency department. Our mobile crisis diversion program is up 100% this year as compared to last year. This year was around this time was COVID was in, but in general, we are well past our pre-pandemic numbers. But I want you to remember, when you're trying to access 211 for mobile crisis, or when 211 is accessed, you have to know that there is someone there who has their eye on that child, who is understanding that that child has some sort of mental health or behavioral health issue, and that they're caring and concerned that that child needs help. We have so many children who do not have that opportunity. Not all of the children in crisis, they're showing up, many of you know, in our budget and in our services through chronic absenteeism, arrested, on the streets, searching for a place to couch surf or their next meal. We have this crisis that's existing that is not going to be addressed primarily and wholly by increasing mobile crisis or increasing beds or urgent care. We have to work together as a public health entity in the state of Connecticut to be able to address the growing systemic racism and barriers to care that Hector discussed just the few in the PRTF. So although I'm here to talk about mobile crisis, and Dr. Vanderploeg is going to actually have much more information around what the recommendations are around mobile crisis, I want to say that we need to have a developing early intervention method of care that is addressing our children in the schools, in the churches, in the community where the children and families are. We have to understand the social influences of poverty, divorce, domestic and community violence as predictors for severe and acute mental health needs. We need to have secondary prevention. Instead of sending the youth to the ED, we need to change the systems and the barriers to care. There are some very interesting things that are happening across the nation around this, in particular related to ambulance or paramedicine. If we were able to convert, work with the ambulance systems, right now there's a pilot going on in Connecticut called Innovating Emergency Triage, Treating and Transport, ET3, so that they're able to deliver to alternative destinations. So instead of the child being called to school, calling 911 to get the child out of the school so that they're having a behavioral problem, the ambulance can come, call 211, and we might be able to bring them to one of our urgent or emergent centers at our clinic. And they're also working on improving patient screening. So I think that the most important thing that we're seeing is that the needs are not simple, but they're basic. That the children and the youth that we see are living in systems and families that are suffering with extreme poverty, with not being able to access the very basic needs of food and care. And Clifford Beers during COVID has been trying in many different ways to address this as a public health crisis. We opened a warm line for the city of New Haven where families call us just to access services. We're one of 8 in the country that are developing an innovative integrated care for kids, where we're trying to develop a system of communication as requested for referrals and targeted case management and care coordination. But we are also doing street canvassing after the shootings in the community, knocking on doors and giving people information about services. So I think that if I was to say 3 things that we need, one is I think we need the state to recognize that as community providers, we are the system of mental health in our communities, and we are not being recognized financially or even understood that the services that we do currently, if funded properly, we can go and build on. Yes, there are workforce issues. I think if we were able to incentivize and help people pay their student loans and do hiring, we could do a lot better job. But the reality is that these systems exist already. They're funded partially by DCF, DSS, OEC, DPH. We're trying to build the systems of care that are addressing from a public health crisis. So I think recognizing the systems are already in place, not looking for solutions in Oregon or in Massachusetts, but developing and investing in the systems that are here today. And that's only one, but that's enough. So I thank you and I'll take any questions on mobile crisis if you have.
Thank you so much. And next speaker is Dr. Wendelbrock, who's with the with Child Health and Development Institute as well. So thank you you're the data person and experience person. So looking forward to hearing your thoughts.
Well, thank you so much for the invitation. Thank you to the committee. I'm going to try really hard to focus on mobile response. I do want to underscore that everything that the other panelists up here today, as well as earlier, have talked about are just underscoring the idea that this is a holistic issue, that mobile crisis, even though I'm going to tell you a lot of detail about mobile crisis, is not going to be the silver bullet to address this issue. And I'm going to try hard to stick to the mobile crisis education and talk with you about data, but I do think it's just so important to consider this holistically, as many of the speakers have pointed out. So I'll start by saying that in our conversations with our colleagues at the children's hospitals and the emergency departments, one of the things that we have heard from them over the years is that anywhere from a third to around a half of young people who present to an emergency department with behavioral health need are not recommended for inpatient level of care. So we have significant opportunities to expand homeschool and community-based care, including mobile crisis, to help prevent those young people who don't need inpatient hospitalization from touching the emergency department. Without a doubt, there are a number of children who present to the emergency department who have highly acute needs, and there's always going to be a percentage of those young people who do need inpatient hospitalizations, and we have to have capacity at that level of care. But the point I'm making is that if we strengthen our mobile crisis service system, if we strengthen homeschool and community-based services in general, we can really make a significant impact in the number of young people who present to EDs altogether. And again, that's part of the solution. It won't solve it all. There's many, many steps involved in all that. That being said, let me just give you a little bit more detail about mobile crisis services. My hope is that everybody that's listening on the committee, even if there are members of the public who are listening right now or listen to a recording later on, will learn more about mobile crisis and all the wonderful capacities that it has to address children's needs in the community. Mobile crisis is a statewide community-based service system. It's been in place for a number of years. It was strengthened significantly about 12 years ago. We have a system network of providers. There's 6 primary contractors in the state that operate 14 sites across the state. And collectively, those 14 sites provide coverage for every city and town and school in the state of Connecticut. And I think that's sometimes something that the public doesn't know. You can call 211 to access mobile crisis anywhere in the state of Connecticut, and they'll be deployed to any location in the state. There's no limitations in terms of which cities or towns are covered. Mobile crisis also is available free of charge. So it doesn't matter whether you have commercial insurance, whether you have Medicaid, Whether you have no insurance, mobile crisis is going to come out and they're going to see you. The other important thing to know about mobile crisis is that crisis is defined by the caller. So there isn't a clinician who says, I'm sorry, your concerns don't meet our criteria. Mobile crisis goes regardless of their determination about whether it's a significant enough need. Mobile crisis is going to go whether it's a emerging concern or whether it's a highly acute concern. So what happens once mobile crisis arrives on site? Well, they provide rapid stabilization of whatever the situation happens to be. They do that in your home, they do that in your school, they do that in a community location. They also do that frequently in emergency departments, and I'll share some data on that in a moment. Mobile is staffed by licensed and license eligible psychologists, clinical social workers, marriage and family therapists, professional counselors. And there are three primary components to the system. First, the statewide call center that's operated by United Way 211. Second, the network of community-based providers, Clifford Beers included, as Alice was talking about earlier, and many other community-based providers that operate mobile crisis across the state. And then the third component is the Performance Improvement Center, which is operated at CHDI, and we're responsible for the data analysis, training, and workforce development for the statewide network of providers. So as I mentioned earlier, what happens when mobile crisis arrives? They provide, first of all, that mobile response. Let's not forget how important that is. There are not many services that will get in their car and drive out to where the location of the crisis is. And oftentimes, and our data demonstrates that the median response time is 29 minutes. There's not very many services that are available in our system that do that. So it's a very, very important part of the full continuum. When they arrive, they are specialists and experts in stabilizing crisis situations, as the name of the program would suggest. They are also very effective at diverting from the emergency department whenever that's possible and maintaining youth, including youth who have fairly highly acute situations, maintaining them in home and school and community locations without having to be sent to the emergency department or admitted to an inpatient hospitalization. So it plays a really important diversion role in the system. They offer screening and assessment of conditions. They provide follow-up services for up to 45 days, but there's really not a limit on that because if you call again, you can get another 45 days. So there's really not limitations on the number of episodes of care. They also have access to psychiatric evaluation and med management, so there's psychiatric oversight for the program. And then importantly, they provide referral and linkage to ongoing care. So within that 45-day window, ideally, you're making the connection to the next level of care that's needed for families. So we have over the years that we've been involved collecting data, seen significant increases in utilization of mobile crisis over the years. When we first got started collecting data about 12 years ago on mobile crisis, our baseline data suggested that we had 5,000 episodes of care per year. That was around 2008 or 2009. When we started collecting data around 2010, 11, 12, implementing this crisis defined by caller, high rates of mobility, we saw immediate increases in utilization, and that has not really slowed down. Before the pandemic hit, we went from 9,400 episodes of care in 2011 to 12,300 episodes of care in 2014, all the way up to 15,306 episodes in fiscal year 19 before we saw some reductions as a result of the pandemic. So for the last couple of years, lower utilization, although as Alice mentioned earlier, we're seeing volume now return to pre-pandemic levels for many sites. Who refers to mobile crisis? So the number one referrer is actually schools. And it's great that more schools are calling mobile crisis over the years, but I'm a firm believer that schools could call mobile crisis a lot more. Some of the national literature, for example, suggests that up to half of kids who present to an emergency department being referred by a school don't require the emergency department level of care and won't be admitted to inpatient. That means there's a significant opportunity for mobile crisis to be doing more in schools. They're already there a lot, and I want to make sure I'm very clear. And we've seen huge increases in school utilization of mobile, but there's more opportunity there. We've also seen over the last couple of years of the pandemic an increase in referrals from the emergency departments. And I'm just looking at fiscal year 20 data, about 9% of all of our episodes of care in mobile crisis were referred by EDs. That's about 1,090 children. This past year in fiscal year 21, it was just about 14% of all referrals to mobile were being referred by the emergency department, meaning the child had already been transported one way or the other to the ED, and the ED was now calling mobile and saying, we need some assistance helping with this child. So in last year, from 1,089 in fiscal year 20 to 1,465 referrals of youth from the EDs to mobile crisis in fiscal year 21. A couple of other things I want to say about availability in the community. We pride ourselves, Connecticut's mobile system, and I unabashedly will say we have the best mobile crisis system in the country for children. We have consistently high rates of mobility. Some of the states that we talk to, and we talk about mobility and how frequently do you actually go out and provide a mobile response, they might say, well, first of all, they might say we don't know because we don't have the data. We do have the data, and we can tell you that almost 96% of all referrals for actually receive a face-to-face mobile response. That's exceptional. It's unprecedented in the country as far as we know. We also have amazing response times. For a mobile service system, we have a median response time of 29 minutes, and 83% of all calls requiring a mobile response are there in under 45 minutes, which is our statewide benchmark that we work with our providers around. So this is a very accessible, mobile, quick. Now, 45 minutes can seem like a very long time. And as volume continues to go up, our providers are more and more stretched to hit those 96% mobility numbers and to get there in a 29-minute median response time. So there can be more capacity added to mobile crisis so that they can continue to do this very good work out there in the community and make an important impact on ED volume. Last two things I'll say, and then I'll stop. We are able to collect some data on the return on investment of mobile crisis from a financial standpoint. Many young people who are seen by mobile crisis in an emergency department are marked as being an inpatient diversion. So essentially, children who are in the emergency department who, if mobile was not otherwise available, may be admitted to an inpatient unit. And that saves, we've calculated around $5 million or so per year in averted Medicaid costs. And we also commissioned a study by UConn School of Social Work a couple of years ago where we looked at Medicaid data, and we followed young people forward for 18 months who used mobile crisis, and we compared them to young people who presented to an ED, and we followed their ED utilization forward for 18 months and compared those two groups. And what we found is that young people who used mobile crisis first had 25% lower rates of subsequent ED utilization over 18-month follow-up period. That's a big deal. As far as I know, one of the only or few studies that's shown the impact of a program like mobile crisis in the community for reducing ED utilization. So let me just offer a couple of ideas and recommendations. First of all, would encourage the committee and everybody who's involved in this work, again, as all the panelists have talked about, to think very holistically about this issue. Mobile crisis is part of the solution, but the needs are comprehensive and they affect all levels of care. That presumes that we have a workforce that's available to deliver those services. So as we've been saying recently, we could have an idea about 12 levels of care that we want to enhance and improve. But if we don't have the workforce and we don't have the funding and rates to support it, we can't do those things. So it's just critically important to get that part correct first because it drives everything else. I think we need increased capacity during the daytime and the evening hours, but I think particularly the daytime hours for mobile crisis. Overnight capacity of mobile crisis is important, but mobile crisis is overwhelmed during the daytime as well. We need capacity there also. We talked about workforce issues. It affects all levels of care, and we need the funding and the rates to support an expansion of mobile crisis. Third, I would say let's work on optimizing school collaboration to make sure that schools have a culture that welcomes mobile crisis into their doors, because if we can disrupt the pipeline from schools to the emergency department, we'll see fewer kids showing up in the emergency department. But that presumes that we have strong levels of collaboration between mobile and schools. And likewise, I think mobile can play a significant role of helping the emergency departments move young people who are not recommended for inpatient level of care, moving them quickly and linking them to community-based services. And then finally, and this is a little bit away from mobile crisis specifically, but I do think it's incredibly important. We have a work group right now that's exploring the addition of behavioral health urgent care to our system. And imagine a system in which mobile crisis responds to a family and is able to make a connection to a behavioral health urgent care that's an appropriate behavioral health specialized unit that is outside of the general medical emergency department. Success, and we do this work, one of the markers for success for me at least, would be a significant reduction in the number of young people who present to the emergency department at all if they have a primary behavioral health condition. We're going to know that we're doing a good job in this system if we see those numbers dramatically decrease, but not decrease in a way that suggests what is it that they're getting. They need to be getting services, but many of these young people can receive services through mobile crisis and homeschool and community care. So I'll stop right there. Thank you.
Thank you so much, Dr. Vanderbroek. I just wanted to, I saw some of your slides and I wanted to clarify a couple of thoughts. And I'll make a statement and you can say that this is plausible or it's inaccurate. If you look at 2020 and 2021, the number of episodes of care and the calls that have decreased. And then you look at the next slide, which is the referral sources, the schools are much less likely to be calling. That's because the schools were closed during the pandemic, but because the schools were closed, the number of calls decreased. And because the number of calls decreased, the ones who needed help did not get the help. And hence we're seeing a significant increase in the emergency department visitations. Is that fair connections?
I think these are complex issues, but I do think that that's a fair characterization. I think as schools were closed throughout the pandemic, the need for mental health care didn't disappear, right?
Yeah.
And many children do receive behavioral health services in schools, right?
Yeah.
So losing that connection was significant for many young people with behavioral health needs. I do think that part of the increase in terms of the percentage share of young people that were referred by emergency departments is in part attributable to the fact that schools were closed and families struggled to figure out who do I call? It's another point that I forgot to make about mobile crisis in terms of recommendations, but the need for community outreach and community and family education around the availability of mobile crisis and what it can do is a constant. It's the way that I've talked about it sometimes. For every 17-year-old that sort of ages out of the youth mobile crisis program, there's a new 6 or 7-year-old who enters in. So the need for education is constant. And there have been a lot of efforts that DCF has led over the years to make the service available, accessible, and to make the public aware that it's out there and exists, but it has to be done all the time. And so
Yes.
you can't underinvest in communicating about mobile crisis.
Yes, Dr. Forrester.
Thank you. I just wanted to add a very interesting thing happened during COVID in terms of referrals. Actually, principals in schools started to increasingly refer for care coordination. And the reason being is that families would be calling them saying, we're in desperate need, we don't have the basic needs for the home, or we don't know what to do. And for us, that was a very important moment because we've been doing care coordination in the schools in our school-based model for a long time. And finally, I think that the schools were beginning to realize how the whole needs of the family were critical for the health and wellness of the kids. And so by doing that kind of outreach for the principals, that actually, we saw an increase across the board in our care coordination in the city.
That's very helpful. Yes, go ahead,
I
Doctor.
just wanted to make just a quick point about the comment about the change with schools and kids not being in schools and the pandemic. I just want to make sure that it's really clear. This is not a temporary crisis that we're in. The data clearly shows an increase in mental health utilization by children. We were sitting and having this conversation 6 years ago under the Malloy administration, in which an ED crisis was declared, right? And we're in the same position we were 6 years ago. I think if we take a temporary view of this and we think about programming and funding to just stop the bleeding, we're going to be in the same position, but worse in another 6 years. Kids are dying.
Yes. Actually, you read my mind because that was going to be my next question, which you've already answered, is that while the pandemic has highlighted this issue, the reality is this is an issue. And this issue is the trajectory is going to move unfortunately, in the direction it has been, and it's not going away. And we'll have to put our resources and efforts and collaborative coordination that is necessary to take care of this, whether there's a pandemic or not. And that's important. I think you had a comment you wanted to make, please.
Thank you very much. Just to dovetail on what you all are saying, I mean, I'm sitting here nodding because, we've all been forced to look at this because of COVID. But the truth of the matter is that this problem has been brewing for so long. And so that gives us significant challenges on how we fund it because, ARPA money, that's got to go towards COVID things. So we have to get our mindset, and I know you guys know this, so I'm sort of talking to my colleagues here. We have to get out of the mindset that it's going to be raining money from the feds and let's figure out how to utilize it. That's not really what we're talking about during this particular panel. This is long-term issues that have started long ago and will continue forward. So we have to, as legislators, make a real commitment to funding things that actually solve the problem instead of putting the Band-Aid on. And so I agree with you on that. But I do have a question. You said that mobile crisis reduced ED utilization. You had numbers behind that. But I think, like, I'm listening to you talk, and for me, another big question: do you have numbers that state how much mobile crisis has kept kids out of the juvenile justice system from referrals from schools?
That's a great question.
Oh, thank you.
And I would encourage my provider colleagues to talk about what this looks like in practice. But to answer your question, I would say yes. If you think about, I mentioned earlier the pipeline of school referrals for young people who would otherwise go to the emergency department, mobile crisis can play a very important role for disrupting that pipeline from the school to the ED. There's also a significant issue that you may have heard of referred to as the school to prison pipeline over the years. And mobile crisis similarly plays a disruptive role in that pipeline. So we were, over the last 12 years, we worked closely with DCF and with the Court Support Services Division, as well as with the State Department of Education now over the last several years, to develop an innovative model called the School-Based Diversion Initiative. Part of that model is strengthening the collaboration between mobile crisis and schools in the service of juvenile justice diversion. So it's been a little while since I've seen the data, but I know between 15 and 20% of all juvenile court referrals emanate from a school-based incident. And that was why we developed the model. And we have now implemented that model in over 60 schools. And the data that we've collected over the years suggests anywhere from a 35 to 45% reduction within one school year in the number of juvenile court referrals from that school.
And what age group is that?
That is typically for high school students, because generally speaking, it's high school students who are at highest risk for being arrested in schools and then entering the JJ system. Although there are some middle schools, and we have been in a few of those middle schools over the years, that make a significant number of referrals to the juvenile courts as well.
But elementary schools as well, because the Office of the Child Advocate came out with a report that stated there were numerous incidences in the Waterbury school system where children were having behavioral problems in the classroom and the police were called. And so when we discuss these things, our concern is obviously that we don't think at any time should an elementary school call the police on a child. You're right. And so for me, that easy idea would be then to require that there is a behavior issue in an elementary school level that requires some sort of intervention from an outside service, that we require that elementary schools utilize the mobile crisis service rather than the police department. That is something that we are talking about and possibly working on for next session. The concern though now is in my brain, I go, okay, I know that works for elementary school kids. It just makes sense. But when we're talking about middle school and high school kids, we can't do that blanket mobile crisis call because we're talking about older children. We're talking about different levels of possible violence. We're talking about different problems in an adolescent and a teen than there is for a 6-year-old. So just something, you don't have to answer it now, but just something I'd like you guys all to think about on the panel is if you can get to us your thoughts and ideas on how we can figure out how to make mobile crisis work on the elementary level. I think we're there. But is there a way to kind of weed out the possible mobile crisis calls from other more serious behavioral calls that we
Mhm.
can handle here as a policy
Mhm.
and possibly legislatively,
Mhm.
and then help you guys to get schools to see that. It's not, I mean, Dr. Forrester, you're going to answer, but I think that it's something also that I would like everyone to sit with for a little bit and get us something written, but please go ahead.
Absolutely. I'm sorry. I just want to say that there's a couple of issues that need to be addressed in this problem. One is around race, and really understanding how people perceive what an issue, a behavioral health issue looks like. It may look, the behavior may be the same, but if the racial difference is there, it may be identified in a different way from a arrest record. And also to connect this to the work that's being done in the cities around the CAHOOTS, or the behavioral health model response for police. I know Norwalk and New Haven are very involved in this. I think different cities are looking at how do you begin to ascend behavioral health response as opposed to a police response, for an area that can be dealt with social workers or with psychologists. So that might be another nice bridge for this committee to consider.
Absolutely. Thank you. And then just one last question. And this goes to the village. Of your kids in PTRF, over the past few years, what percentage would you say of those kids that are in your system at the top of the pyramid, the most intense interventions and the residential treatment, have already had some sort of involvement in the juvenile justice system?
So our PRTF is targeted for children 6 to 12 years old, which is very different than what SoulNet has or the Children's Center of Hamden. We have the percentage who are involved with JJ tend to be small.
Because of the age group, you would assume.
There are two pieces to it. One, because of the age group. The second really is, at the village, we are located in Hartford, primarily serving the sort of the capital area. We serve people of color. And to a large degree, that is our population. The place where that is not true is our PRTF. Our PRTF is much more representative of the state of Connecticut, partially because it's statewide referrals. But going back to the description that Alice gave you, if you end up in our PRTF, someone has identified you as having a behavioral health issue, someone has tried to do some interventions. You've done several things before you end up with us.
Top of the pyramid,
Yep.
almost last step.
Yeah.
Right.
And so kids who end up in JJ oftentimes don't get identified in that way. They get not identified as behavioral health issues, but as conduct, as oppositional, or as criminal. And so it's those divergent tracks that sort of lead to what we see for the 6 to 12-year-olds. I imagine SoulNet and Children's Center of Hamden would have a different aspect.
Well, thank you for your input.
Yeah, and just, I mean, I think the other piece is this is a systemic racism issue, right? Is like the kids that are funneled and identified as having conduct issues are not funneled into mental health, even though they have trauma that is usually quite extensive, right? Even though they do, in fact, deal with anxiety and depression, that's not what's identified. It's their behaviors that are pointed out the most. I think one of the things that is lacking and I think could be served at a higher level of care is really being able to identify those kids who might have been funneled into juvenile justice, but you need to have specialized individuals who can work with kids who are able to kind of get to that anxiety piece of it, get past those layers. Also addressing the issues earlier on, right? So that it's not getting to where they're seeing mental health for the first time when they're, in some sort of juvenile justice facility or, or a program. But I think that it's just something that we in Connecticut haven't really thought to do such a great job with, frankly.
Well, we're going to try to work on it. Thank you very much. Dr. Forrester, if you'd like to stay for this this panel coming up now as well, we think you'd have a strong voice here as well. We'd like to call panel 3, Outpatient Service Array, with Heather Gates, the President and CEO of CHR Health, and Gary Steck, for Chief Executive Officer of Wellmore. Hi, folks. Thank you for being here today. Gary, if you'd like to kick things off for us, thank you.
So PowerPoint won't be available?
You brought a PowerPoint?
Yeah, it's okay.
If Peter in the back could hear, and
It was already, I'll for the sake of time, I'll just cut to the chase. That's okay. So
Okay, great, thank you.
Wellmore is a Waterbury-based 70-year-old nonprofit that serves lifespan, very large child population. Pre-COVID, maybe 11,000 clients a year. COVID, a little bit less, around 9,000. Large continuum of services, addiction recovery, residential, mobile crisis, outpatient, home-based services, 25 or 26, mostly state contracts. My agency is an enhanced care clinic, and also is a mobile crisis intervention center, formerly known as the MPS. So maybe quickly, I would talk a little bit about what have we done so far. So our focus was a little different than others. We went a little bit all in initially and decided that we were going to maintain face-to-face capacity, and with some support from the commissioner and her staff, we actually opened up face-to-face services within a few weeks of the beginning of the pandemic and figured out creative ways to see people by using tents, drive-through circumstances, home visits, parks, and whatever we could do. Our approach was to maintain walk-in capacity and same-day services because in our community, and it still to this day remains the case, that mostly virtual services is what's available. And we found that while that is an important tool, what's most important and most empowering to parents and real people in real life is to say to them, what do you need and how do you need it? It hasn't been easy, and resources are absolutely in question, but we have found that it's highly effective. And in fact, over time, as more and more providers and even maybe some private practitioners are now beginning to see people face to face, they're consulting with us about how we did that. But in fact, because it's all about relationship, there are some circumstances where it works well and some circumstances where it doesn't work well. But what's most important to us is that what families need, we need to be able to deliver. We had the unique opportunity, again, in partnering with DCF, to pivot some of our resources. I'm going to talk about practical things, right? Try not to use jargony terms. There were some real pressing local community needs within a couple of schools, and I was fortunate enough that the commissioner staff allowed me literally to pivot some of our program resources from one thing to another during the pandemic to address that need. So I'm just going to put that out there as an example of something that worked in the past that we should think about for the future. Because really, in the context of an emergency, does it really matter that something is funded for this or that? It's really, what do we have to do to support children and families, our citizens, help people live healthy lives? And in fact, that could happen. And really, even though it sounds like a really complex thing, it really was a matter of communicating effectively with people and then focusing and delivering. So we ran a couple pilots in schools that were really engaged in Waterbury in particular at helping reach kids that were not connecting in any way, shape, or form, because we had so many home-based programs, and because the staff were actually in office, we were able to deploy them to follow up where the school could not, and go to people's homes and try to engage them. We enhanced our nursing capacity. Really hard to find nurses, but we saw it coming that there's been a great increase in requests for consideration of psychiatric medication. There's a shortage of psychiatrists. APRNs are dominant in Connecticut, and found this to be a really important resource. We encourage planning for what actually is now occurring, and it is, to be honest, in some ways it's a frustration that we're here today talking about some of these things that we had hoped we could have planned interventions for so that we would already be implementing them. But I think that that's easy to say when you look back now because the pandemic was so horrible at the time. There's only so many things that everyone could focus on. A big part of our effort was meant to try to stabilize our workforce. We did not let anyone go, except many people left us and relocated to wherever they needed to, or decided that this wasn't for them, or they were uncomfortable seeing people face to face, or they simply went to a higher paid position. And we obviously spent a great deal of time focusing how to keep things safe for our clients and for our staff based on day-to-day, moment-to-moment feedback. Because I want to leave time for my colleagues also, I'll just focus on a couple of suggestions right now. So Children's Outpatient is an anchor service. And realistically, there's a lot of exciting things. I'm involved with a lot of planning forums. There's a lot of things that are being talked about that are creative solutions, but they really involve standing up new programming. And I think that some time and effort should be put into that, but in my opinion, that's mostly unrealistic as a short-term project, in that there's such challenges to starting new things. There's workforce problems, and there's so many complexities to some of the things that we're talking about. So I think it's absolutely essential that resources be pivoted, and I mean money, be pivoted towards stabilizing the children's outpatient system, that we simply have to find ways in which we support this workforce that already is carrying large caseloads. None of us can afford to have any of our staff leave at this point. We actually need to find a way to reduce their caseloads, because the nature of the children that are presenting now, because many of them deferred care, is much deeper, more challenging, pressing needs. Our colleagues before talked about MCIS, formerly known as EMPS, right? Sounds like a TV show. It's not 24/7. It needs to be 24/7. I mean 24/7 mobile. It needs to be fully funded 24/7. And the EMPS providers, MCIS providers, are based on the actual data. You can see that the providers have been very effective at pivoting their resources to make sure that they met those two key benchmarks. And remember, for MCIS, there's actual external data to the providers, which is unusual in the legislature. You get reports on this in a way that's much more comprehensive than many other behavioral health services, to see the actual impact and even the money that gets saved by the project. This project is the second pillar, and it can't do everything, but it absolutely is essential right now that resources be made available. We can't stand up new services immediately, but we certainly can build off of what we have, and hopefully even pivot some of what we're already doing into this, because as my colleagues have said before, now that the schools have done a great job bringing kids back in, the volume is much higher, and there are hundreds and thousands and maybe tens of thousands, we don't really know, of families that deferred care. School-based interventions are helpful, and I get that, but I would also say it's really important to remember it's families are a part of this. So individual care does matter. The data on individual interventions for kids in school is relatively modest. We spend a lot of our time focusing, and I think my colleagues would say the same thing, in trying to engage the whole family and not making the child into the problem. So we're seeing and hearing more about fighting in schools, all kinds of, if you will, acting out behaviors that are problems. We see these things as systemic. We see the family, the parents, the caregivers, the system around them as essential. We need to strengthen them. We need to support them. And so I certainly think crisis intervention and outpatient are a piece of that, but it has to be based on how can we help families. And I don't believe that this is for the short run either, in that resources have been tough for many years. And the fact is that all the projects that we're talking about right now have not really received any new funding in a decade, which is a real long time. And you can see from the data that Jeff presented that the volume, even from mobile crisis, has radically increased during that time. Pivoting existing resources. So I think that the state agencies that are here, I understand that there's new ways in which they're working together. And I think that modeled for us, that then we can go back to the state and say, if you have the time to talk to us, we think we can do things differently to meet community needs. And I think that that's where Connecticut needs to be right now, is rethink, break down the barriers, try to make quicker decisions, but to find creative solutions, because we're not going to have the resources for everything, but together we really can make a difference. And I'm a big believer in trying to keep it as simple as possible, that the terms that I'm even using today may not sort of be digestible for families. And my family reminds me not to say egghead terms, but it's really important to families about what they need. So what do families in Connecticut know about? People know what outpatient care is, and people know what crisis care is. So if they want outpatient care, they need to hear that it's there. They need to hear that it's readily available, maybe even same day. I think many of the ECCs are still able to do that, maybe even a walk-in that day. And a crisis call, it doesn't matter whether it's at midnight, 7 a.m., 3 p.m., whether it's in the school, a church, or whatever, unfailing, it has to be there. So you miss that opportunity, then we're going to add to the deeper ends of the system, which are very complex and are quite challenged. And then lastly, I would say, and it can't be said enough, we absolutely have to do everything that we can to re-engage, reconnect, and ask families what they need, how they need it, when they need it. This has always been a big a hallmark of what's happened in Connecticut, but obviously with the pandemic, that's been very difficult to do. And in most of the planning things that I've been involved with, I'm sorry, the families really have not been a part of it. So even today, I feel somewhat embarrassed. I'm making these suggestions, and some of these are guided by families that I have talked to, but in fact, some of them are not there. And I really feel like we need to do a better job of that. And lastly, I would say another practical solution is something I'm just going to call this the lighthouse concept. And that is that since my belief is it's really hard to stand up something that's new and you have to build off of something that already exists, the enhanced care clinics, which are based throughout all of Connecticut, really were never fully actualized. And I believe that they could become, and maybe 6 or 8 of them across the state could be something like a lighthouse, where they are a shining resource in the community, a blinking light for people to go to if they had better resources, where they could have dedicated staff that dealt with fairly acute people that walked in that then could be deterred from the emergency room, but we would need dedicated staff, which would include psychiatry and nursing for that. I know that there's talk about urgent care centers and those kinds of things that would have beds with them, but I believe that if we had dedicated resources for that in the communities, that we could more quickly walk people out of the emergency rooms. And so some of you would know that my agency actually, as a mobile crisis provider, we're actually in one of the emergency rooms face to face and work on every single case. And we've had a high degree of success in walking people out. But there are 5 other hospitals in our region that do not permit mobile crisis into their facility. We would like to be able to do that, but frankly, we would need more resources to do that. But I think that there is a potential opportunity if we can build off of these. I don't know, maybe it's in the larger city settings because that's where there's a higher volume right now. I'm not really sure what the right idea is, but I believe that together we could pull these things off relatively quickly. But there's resources that need to be there with it, so that when families could know that if they needed urgent care, that was a place that they could go. Lastly, I want to really thank you for the opportunity and for all the work that you're doing and for all that my colleagues are doing. And I will pause so that they get to speak. Thank you.
Thank you very much, Ms. Gates.
Good afternoon. It's nice to see you and nice to be here for the first time in over 18 months. So it's great to be back at the Capitol. Appreciate your interest in this topic. It's obviously critical for the state of Connecticut and for the children and families that we all try to do our best to serve every day. Let me tell you a little bit about CHR and the work that we do, and then I'll address specific issues related to our work with children and families. CHR is one of Connecticut's most comprehensive and largest behavioral health providers. We provide services throughout more than half the state. We go from the border with Massachusetts down through Hartford, New Britain, Middletown to the shoreline, and throughout all of eastern Connecticut. We have 10 outpatient locations. We have multiple residential programs, including programs for adults with substance use challenges, as well as therapeutic group homes for children. And extensive in-home services. About half of our work is provided in the community through outreach programs, both for children and families and adults, all of which are evidence-based models. We also are doing some very innovative work with the Department of Correction. We operate 6 methadone clinics in 6 different prisons, and we work with those individuals upon their release when they return to the community to help them connect to care and also very often connect with their families. And that is some pretty critical work that's happening right now. We provide foster care, we do housing. In essence, we provide every service that a child, a family, or an adult would need that has significant behavioral health conditions, including all the support services and addressing social determinants of health. We serve about 27,000 people every year, and we employ over 900 individuals from a variety of backgrounds. I am very proud to say we are also top workplace in Connecticut and have remained so, certainly more of an honor during the pandemic than ever before. Our staff are amazing and do an incredible job providing services and supports to those that we support in the community. In our child and family system, we offer every level of care. We have outpatient, we're an EMPS provider. We are also an adult mobile crisis provider. We are a certified community mental health clinic. We are a local mental health authority. We have care coordination, both funded by SAMHSA as well as the state of Connecticut, working with extremely high need children and children with comorbid medical conditions as well as behavioral health conditions. We have a family medicine clinic that works with adults and with children. Therapeutic group homes, which I've mentioned, and our work in schools and pediatric practices. We are currently running clinics in 34 different schools and 7 pediatric practices. The pediatric work has really been facilitated by the telehealth work that we've been doing, and we hope that that will continue. In FY19, to give you a sense of numbers, we served 2,800 youth in outpatient alone. That went down a tiny bit in 2020 and 2021, but it is now rebounding pretty rapidly. During the pandemic, the schools were obviously not seeing kids in school, and we saw a real drop off in attention to mental health. That has changed dramatically. Now that kids are back in school, we're getting requests from lots of schools to open clinics in the schools, which we are able to do, and then also to respond to children when they are in need of our various programs. Our outpatient level of care, it's really the level of care that is essentially sort of the front door to the system other than the crisis system. And it is holding those kids and families that are often waiting for higher levels of care, some of the in-home teams, some of the residential programs, sometimes inpatient care as well. And so the staff in those programs are really working with exceptionally high need kids. Outpatient is sort of seen in some ways as a lower level of care than some of the other services, but in fact, they are working with children and families who have some of the broadest needs and right now are really in acute crisis very often. This is also where we're having major workforce issues. As you've probably heard from other panelists today, we have not received adequate rate increases over the years. And in fact, the last 10 years have not received a rate increase at all. The Medicaid rates have not gone up at all during that period of time. That's a travesty in a state that has so many resources. The 4% that was allocated July 1 by the legislature, signed into law by the governor, has still not been distributed to us. In the meantime, we are losing staff because they can be paid higher salaries in a multitude of other settings, and it's a struggle to keep up with that. So we know that this is focused on many issues, but we would urge you to really bring attention as well to the need to adequately fund the services and the different levels of care. We cannot work miracles with the resources we get. Our outpatient clinics are losing money now. They lost money last year. We received no money to help with that from our major funders. So I would urge you to look at that. As an organization, we utilize evidence-based practices in all of our levels of care. That needs attention from the state. I think it's critical that all providers are really required to use evidence-based practices. They do work. It's possible to track outcomes and use those outcomes to adjust the work we're doing and to improve what the individuals we serve receive from us, and ideally help them with their care, their treatment, and for adults particularly in their recovery. We need to address the workforce crisis, and that's just a given. We need to do it through more funding. We need to do it through help with student loans, with providing money upfront to help people with bachelor's degrees go back to school and get master's degrees. It is critical if we're going to provide the services that are needed. The need for more staff is just immense at this point. So I won't go on much longer. I just want to thank you for your attention to these issues. I think we need to shore up our core service system first and foremost. We know what we're doing. As a provider, we know how to meet the needs of kids and families. And so we need to be given the resources to deliver those services and to build on what is there, not necessarily go off and create a lot of new programs and services at this juncture. So thank you.
Thank you very much. And Dr. Forrester, if you would speak briefly about school-based health centers and school-based mental health.
Sure. You heard some of the work that Gary was talking about, as well as Jeff was talking about the school-based diversion. Clifford Beers was called to be the recovery effort in the Sandy Hook School on 12/14 with my colleague, Gary Steck. We were there from that evening forward. We were then asked by the commissioner to be the recovery in the school that was impacted. We had clinicians there for 6 years, following the children all the way through to their transfer into high school. So the 2 or 3 days after the event happened, we debriefed with all staff, and our staff sat in a large circle in a gigantic room, and they said, we're very devastated what happened in Sandy Hook, but this happens to our kids all the time in our community. What about New Haven? What's going on around trauma-informed services within the schools in New Haven? And so at the same time that we did our work and developed our work as a trauma response within the Sandy Hook School, we took that learning and we have developed a trauma-informed work with partnership with DCF in the New Haven Public Schools. And in those schools, what we've done is we've been able to bring care coordination, which is wraparound working outreach for families, as well as evidence-based cognitive behavioral treatment for trauma in the schools, or bounce back, and individual therapy. It is not a school-based health clinic model. We do also use a school-based health clinic, and we are in 2 school-based health clinics in Connecticut, in New Haven, but it's different than the typical medical model. We go into the classroom and we screen, we offer workshops around trauma and adversity, and we screen the whole class. And we have found that somewhere between 40 and 60% of many classrooms across the state have children who are living with anxiety, depression, and/or clinical PTSD. And then at that point, we then begin to reach out to the families and ask if they're interested in their children to participate in these evidence-based treatment groups. We are seeing with this combination and also a lot of education to the school staff themselves. And in Sandy Hook, one of the things we had was actually a therapist available for the teachers, which went a significant way in the school because the teachers were certainly victims themselves, but also trying to offer that kind of support services for the educational staff, because as you heard, the medical staff, our staff, everybody is burnt out. But anyway, in general, what we are seeing in this kind of a holistic intervention is we're seeing at the beginning, chronic absenteeism being somewhere between 35 and 45 days. With this intervention, we're able to go down past underneath what is defined as chronic absenteeism, not 0, but below 18, which is the number in the state. We are seeing reduced about 45 to 50% reduction of post-traumatic stress disorder symptomology. And we are seeing that families are reporting that they can handle and manage their children in a much better way. So those are, facts that I can certainly back up with data that we've done study and reporting with DCF. But this holistic model of care within the school that is not a medical model, but as Gary said, a whole family, whole person approach, we see as having great impact on a lot of the issues that our children are seeing. I want to just say that over the last week, we've received a call from probation staff saying that they are incredible suffering because they lost a child, a 14-year-old in their care. We have our school-based staff. We're outside a school in New Haven where an active shooter event happened out on the street while the little kids are playing on recess. And what we've had to do is actually call in mobile crisis, call in anyone who's available in our community to be able to help not only the children, who, by the way, were not as impacted as the staff were, who were teaching in the school. So, we are deployed. I'm proud to sit with my colleagues here and others, and Hector. We are deployed in the community. We are the people the community calls for. We have been responding despite no increases in our work. If you looked at our numbers served 10 years ago, we are probably about 300% increased than 10 years. And I have, and Heather and Gary have had to find multiple alternative ways to fund our work, which we know is the right way to do. And we are the Connecticut state system. So it's very unfair where we've been. Thank you.
Thank you very much to all of you. And we understand that funding is absolutely a significant issue. I know, Gary and I have had multiple conversations about that ourselves, and I recognize that, and we are working every day to have those discussions with our colleagues because we need to have them understand the depth and the breadth of what the issue is and how it does come down to funding. I do just have one question. That would be for Dr. Forrester. When we're talking about the holistic model of care, the program, this is one that, I get really excited about. It just sounds to me like this is where we need to be going. So I'm wondering if you can give me a little bit more information. So do you open this up to any community? Did you have certain communities picked out that you wanted to try first? Is it a pilot program? How is it now being implemented and where?
So I would say that all of us are working together. I mean, Heather describes as a holistic agency. We became an adult licensed clinic in response to seeing the need that it's not just the child who's the identified patient, but the parents also need to be served in the community. We have been expanding right and left the care coordination services that are currently not funded by Medicaid or DSS. All of those extra services that we were talking about, basic needs. We are one of this innovation sites in the country, working in close partnership with DCF and DSS and other agencies to create a wraparound holistic model system for the 30,000 kids on Medicaid and pregnant and parenting women in New Haven. We're restricted to the New Haven community for this particular pilot, but we're not the only people in the state who are doing this kind of work. Waterbury has active programs.
Right, but you're talking about kind of the holistic program in general. What I'm actually referring to is going into the school, assessing the children in the classroom.
Right.
Where is that? How is that? Who is funding that?
Oh, that's a great question. So we have a grant from DCF that pays for a portion of it. Private philanthropist has paid for a matching grant of $1 million. for us in the last 6 years, and we were informed that they're not funding us next year. Their funding priorities have changed. And so we are looking at all of these innovative ways to be able to, and working with DSS very closely, to be able to at least keep the condition of the care coordination going within the schools and partnering. The good news is New Haven Public Schools is going to hire 4 care coordinators if they get through the union and all of those things that you have to get through. But the reality is the funding is periodic, and it can change at any time.
Because this program that you are overseeing is strictly in the New Haven school system.
Well, actually, interestingly enough, one of our sister agency that affiliated with us, Norwalk, Mid-Fairfield Child Guidance, actually Norwalk Public Schools is funding 100% embedded work in their school district.
I mean, so this is, this is where my brain goes when we talk about this. I recognize that urban areas are probably going to be the best to kick off these programs, but I also recognize that it's really good for every single school district in the state of Connecticut and around the country, if we're being honest. And so, the types of trauma might change based on geography, but the fact that trauma is there doesn't. It doesn't change based on geography, and it really doesn't change based on socioeconomic status. Trauma is there, so we have to get to the heart of it. So, pie in the sky, pipe dream. If I was Bill Gates and you needed to sit here and tell me, in order to get this in every school system in some sort of fashion in the state of Connecticut, how much money do you think you'd need to do that?
I would say at least $3 million per district, depending on the size. And maybe Heather will say a different number.
No, I wouldn't say a different number. I would just say that the combination of care coordination and in-school treatment, because both are needed. Treatment alone doesn't get the job done, and care coordination by itself doesn't either.
Right.
That should be a model of care that is available to all kids throughout the state of Connecticut. And whether the funding source is school systems, determined by the Department of Education, which is now what's happening because they're scrambling to figure out how to meet the needs of kids coming back to school, whether it is DCF funding. It can't be Medicaid alone because Medicaid doesn't pay for the services of all kids in Connecticut. Our payer mix is about 50-50, commercial and Medicaid. So that doesn't wholly get the job done. Or whether it is federal funding. And right now we cobble together money from SAMHSA and from the Substance Abuse Mental Health Service Administration, from school systems, from private money. It's a variety of sources, but I think it would be important to look at how to create a consistent funding stream for this set of services, such that, as Gary said, you are meeting kids and families where they need to be met.
Right.
And you're providing services in the locations where they are, and doing it in a way that's sustainable. Because what we're all doing, as providers, we're the way funding gets braided. It gets braided at the provider level because we're going after money all the time in order to provide services we know our kids and families need, and no one source is able to pony up.
And I just want to leave you with one thought before I send it over to my co-chair. Obviously, that kind of funding coming from the state, one source, is difficult. We know we're all sitting in this room knowing, look, this isn't going to happen. But as we move forward as the experts in this type of intervention, if you could consider a way to tier it so that at the very least, all districts have the ability to utilize this sort of questioning for the kids, put it out there. And then if a school system has the ability, then if they have the funding to then be able to do their own care coordination within their local district, and then send the kids where they need to go. I kind of want to look at it as, okay, so there's two ways to look at it. You could do your toe in the water of doing the whole thing with a few districts, or you could look at it as doing the first level with all districts, if they're able to do it, to then see it through to the other end in their own communities. So it's a lot to ask for right now. So let's just sit with it. But, as we move forward in the next couple of months, maybe we can all get together and talk about if that's even a possibility, because the last thing we want to do is start the process and not be able to finish it. Oh, so you're telling me that you have 20% of your children who need next step services, but we can't help you do that. But I'm glad we identified it. I don't want to be in that position. So if we could just kind of move forward over the next couple of months and think about a way that we can tier that, so we can at least begin and we can offer those things to school districts, sort of like an off the shelf program. Say, here's what we'll provide for you, and that provided that you guys can do these next steps, B, C, D, and E, right? Sure. Ms. Gates.
I would just add that, and you'll hear obviously from the state agencies, but DSS has just made a major decision that will help with this, which is to allow providers to expand access in schools through their enhanced care coordination program and rates, and that makes a difference. It's a huge improvement over where we have been. So that's a great first step. What's not funded is the care coordination uniformly. So, thinking about how do we do that? And I agree with your approach, which is look at the incremental creation of what then is a system of support, rather than thinking about, well, how do we do it all at once? Because that is, of course, overwhelming. But, that ECC decision is really significant to the service delivery system.
Great. Thank you guys very much. I'm going to send it off to my co-chair now. Senator.
Thank you, Representative Linehan. Thank you so much for your wisdom and sharing your experience. And I know you had to change your schedules to be here. I truly appreciate it. If you can give me a one-line answer to this question. We have a situation where we have some ESSER and ARPA funds, and this may not be there forever. And then we have long-term funding needs. Let's leave that for the time being. That's going to be a separate conversation. What can be done with the current funding that we have from the federal government that can help the situation right now and not create a cliff?
We absolutely need stabilization resources for our staff. I can say I recommend highly that you go 24/7 for mobile crisis, and that the Department of Children and Families begin rapid planning to see whether they can encourage with resources some core providers to be essentially sort of urgent care outpatient providers.
Good.
2 years is a long time, but I mean, I'd like to think that in 2 years things would be somewhat different, but I think a minimum of a 2-year investment, my guess is that you would have some providers that would be willing to partner in that fashion.
Thank you.
So I would say anything and everything for staff. Retention incentives that are significant, not the amounts that we've been able to eke out of our budgets. A pool of dollars for staff to be able to get reimbursed for educational expenses, repayment of loans, absolutely anything that says to our staff, we value what you're doing. We understand that you are a critical part of meeting the needs of the kids and families in Connecticut, and anything that can help stabilize the workforce. We gave hazard pay to our staff, not because we got money to do it, but because we knew we had to do it and it was the right thing. So we need to now move through this period of time into what the future looks like and think about how do we continue to recognize them without necessarily seeing it as hazard pay.
And I would just add, I know Representative Linehan that this money is not sustainable, but I think that there's a lot of money wasted in the state. And as Heather said, that we're braiding and blending funding on the ground that the state should seriously look at. And I know that there's been a lot of work amongst the commissioners of making sure that those dollars from the feds are coming down in a braided, more supported way to be able to have the outcomes that you want, as opposed to piecing it together at the bottom.
Thank you so much. Thank you. We'll move on to the next person. Okay. Next person is Sarah Egan, Office of Child Advocate, who has been a great resource to everyone in the community, especially both Representative Linehan and me. I think you are on virtual world right now, if I am not mistaken. Sarah
Yes.
Egan.
I'm here. Can you see me?
Yes, now we can.
Okay, good. Yes, I am virtual. So hello to everyone. I'm Sarah Egan. I run the state's Office of the Child Advocate. For those that don't know, the office is an independent state agency that is mandated by state law to do a number of things, including evaluating and investigating where necessary publicly funded services for children, and to provide individual assistance and consultation to children, families, and providers in the community where a child has unmet needs. Specific to children's mental health and the issues we're talking about today, OCA meets regularly, talks regularly with families, sometimes with youth. We meet and talk with folks at the hospitals, the state agencies. We review data wherever it's available. We meet with subject matter experts, our colleagues in the community, to develop recommendations and to conduct public advocacy, like opportunities here today at this hearing. I just want to underscore that, not a day goes by, not a week goes by, that we are not hearing from a family in crisis. Just what we're talking about today, just like we were talking about yesterday, whether it's a 12-year-old child with a morbid level of depression and suicidality who is in the community waiting for services for which there are multi-week wait lists. A child in the emergency department waiting for PRTF level of care who has an IQ under 70 and can't access anything, right? A 9-year-old boy with disabilities and mental health treatment needs, whose family is desperate for support, and the services and the out-of-home care is not available. And these are not new problems, but they are recurrent, they are poignant, they are pressing. And I don't have, by my point in the agenda, you have heard, I think, from my colleagues around the state who are experts at what they do. They are innovators and leaders, researchers, and a lot of the answers are not rocket science, right? They are things that we have talked about for a long time, right? And then crisis creates urgency, but creates opportunity. So I'm so grateful that this hearing is occurring today and that we're having this conversation, and that there are so many wonderful partners. I'm looking forward to hearing from our state agency partners as well about how do we move forward together strategically, quickly, and most of all, accountably. There are a couple things, and I'll be brief, that I wanted to underscore that we talked about today. As we know, these are not Connecticut specific problems that's happening here in Connecticut, but as others have mentioned today, the American Academy of Pediatrics and the nation's children's hospitals have, as recently as a week and a half ago, declared a state of emergency for children's mental health. That emergency will require a meaningful expenditure of resources and attention in order to address it from top to bottom. We've heard about inpatient beds that are full, emergency department utilization and boarding, meaning the length of stay in emergency departments, increasing because of the level of acuity that children are presenting with. We talked about, and I do want to underscore again, additional concerns for certain populations, and a few of my colleagues talked about this today: children with intellectual disabilities, children with autism, children with eating disorders, justice-involved youth have particularly hard time having their treatment needs correctly identified and then accessing care. We must have a specific strategic plan in place to ensure an adequate continuum of care from inpatient bed all the way to home and community-based services for children with these different clinical presentations and needs. We must hold ourselves accountable for those system improvements. We hear consistently the Office of the Child Advocate, and you've heard it here today, about waiting lists for intermediate level of care. That next level that might keep a child out of the hospital, may keep them and their family stable and supported, or that they might need after discharge from an acute care center. I do not have at my disposal, unfortunately, reliable data by region about what care is available at the intermediate level, what the waiting lists are. That data, I think, is really important to inform the investments that need to be made to support, sustain, and where needed, expand that level of care. And we've heard from several folks today, and I thought that Alice Forrester's comments about where health and mental health prevention really starts. It starts at the beginning, and there's so much more that we can do to support children and families. A couple of quick solutions that I think you've heard today that we want to underscore are, and you've heard it from everybody, right? There are structural challenges in our system, but there are things that money and resources can address, whether it's increasing the reimbursement rates and the financial supports to increase the number of child and adolescent psychiatric hospital beds. A lot of folks think we need about 10 to 12 more inpatient beds. We're going to have to put the resources in to create that, either through more financial support or through a public-private partnership that allows for private management from a provider using state infrastructure to help build that bed capacity over the next 3 to 6 months. We need to increase capacity at our PRTF, that's this hospital subacute level of care. Look at the reimbursement rates and the staffing and supports that are needed to address the acuity and the acute and complex presentations of children at that level of care. We need to be looking at reimbursement rates for all of that to make sure that they match children's level of need and the provider staffing and infrastructure needs. And Hector Glynn talked about that based on his experience. One thing that didn't get talked about today was the need for respite. And respite is a term I often say in my office that it's like, respite's sort of like a Rorschach test. Now, what does that mean? I think it means different things to different people. What it means to me is relief. And relief for a family in crisis or dealing with a family member who has a chronic and challenging condition, relief has to be part of the treatment plan. The absence of reliable respite, be it in-home support, community-based support, or even overnight support, creates crisis. Respite is a relatively, in certain ways, lower cost support and service that can be a difference maker for a family that can make it through the week if they know that on Thursday they get an extra set of hands. They know on Saturday there's 4 hours of relief that they don't have to provide single-handedly. That is a part of our system that is not really funded through traditional insurance, but that makes treatment plans for children and families work. When we look at the money, and I really appreciated Senator Anwar's last question about the federal ARPA dollars, I'd want to know how much more is there and what else can be invested immediately to give a shot in the arm to our badly in need outpatient service delivery system. And I think you'd heard it better than I can say it from Heather Gates and from Gary Stack and from Alice Forrester, that there's no short-term solution to the workforce development challenges, which we will need to look at medium term and longer term, but money will make a difference. And so what dollars are available right now from the federal stimulus dollars that can go to our community providers? Alice Forrester said again and again today, the nonprofit sector is the mental health delivery system in every community, right? They deliver this continuum of care, right? It's our hospitals and our nonprofits. They are the ones meeting children in crisis, going out to people's homes. We have to invest in that system. Now, one other thing I wanted to point out is that didn't get mentioned today, or maybe did in passing, is this Boston Consulting Group report that was commissioned by the governor's office to look at these impending state retirements over the next, over the next 6 to 9 months. Big chunks of our workforce, including people that do social services and human services and social workers. Some of the remedies provided by Boston Consulting Group are to push more support and service opportunities to the nonprofit sector. Well, how are we going to do that if we're not investing in the nonprofit sector? So that the urgency to do that is only going to become more heightened as we see a wave of state employees leaving state service between now and the end of the fiscal year in 2022. In addition to that short-term infusion, I think the legislature we are really looking to the legislature to be an important partner on making sure there is an immediate development of a strategic plan to look at insurance and Medicaid reimbursement rates. That, to some degree, I think it's fair to say that state agencies are making up for in their contracts some of the difference from the reimbursement rates for the services being too low. So we can't fix that overnight, but we have to start looking at it immediately. Just looking at my notes here really quickly. So a couple folks today talked about the possibility of piloting or fast tracking behavioral health urgent care. There is a state working group. I'm sure you'll hear more about that from the state agencies today. I would want, what is the timeline for that working group? Is there an opportunity to use current dollars to fast track and pilot urgent care to divert kids from the ED or even from mobile crisis from schools for assessment, stabilization, and maybe a handoff to care coordination? We heard a lot about innovating and expanding use of mobile crisis. Mobile crisis comes with increasingly a big federal match. And there are requirements around that, including the requirement that providers who do mobile crisis have 24/7 response capacity. But with an investment in mobile crisis, several opportunities. One, the opportunity to have the staff at the level that you need and make sure, as Jeff Vanderplug talked about, that the response times, which is critically important, can stay as low as possible. Two, potentially provides an opportunity to differentiate the level of care and how long mobile crisis can stay with a family to bridge them to supports. And third, presents an opportunity to consider embedding mobile crisis social workers in schools that are high need and have been historically high volume referrers to local emergency departments and to local police. We talked a bit about schools, and so I do want to piggyback on the early comments from the committee about new legislation looking at school-based health centers. That was just passed. There's supposed to be a report back to the legislature in February of 2022. So I am not hearing that work has gotten off the ground, but that work needs to be fast-tracked Those recommendations will be critically important to the legislature to look at how districts do or do not have access to school-based mental health supports and how more mental health services can be integrated into the schools. We need actionable recommendations for the legislature to be able to respond to. It was also mentioned, the federal stimulus dollars that came to schools, those are the ESSER dollars that, according to sort of federal spending rules, portion have to be used to support children's mental health and well-being, engagement. And every district does its own thing with those dollars. And of course, needs of communities vary from town to town. But can we have a mechanism and a framework for districts to share information with each other about how they are using those ESSER dollars to support children's mental health so that districts towns can share innovation, share blueprints? Maybe that's something the State Department of Education can or is, perhaps they're doing some of that now. I apologize if that's the case, but provide further technical assistance around the use of those dollars to support children's mental health. And the last couple of things I wanted to say. One is when we talk about prevention, there was a story in NPR this week about juvenile justice and about car thefts. And it's part of a series that they're doing looking at juvenile justice. And the number of people that the reporters talked to who talked about how many children don't have positive, healthy, regular, affordable, accessible things to do in their community, cannot be overlooked. And that predated COVID, but then COVID shut down so much of what did exist. And the reporters talked to a mom whose local school doesn't provide any sports, who works 2 jobs, and so she can't be home with her children, whose son is interested in beatboxing and cooking, but there's nothing for him to do in her community or that she can afford. When we start making sure, we have to make sure that children in every community, regardless of their income level, regardless of their developmental capacity, that they have access to recreation, after school activities, pro-social and therapeutic programming after schools. Our schools can be community hubs. They don't have to close down at 4 o'clock in the afternoon. Too many children lack the opportunities that other children have. And that is something that is also relatively low cost that we could invest in. One point I can't resist making about the cost issue, and Representative Linehan asked, of course, a very important question about how much would it cost to bring a model like Clifford Beers is doing in the New Haven Public Schools, across the state. Well, I've talked with Alice Forrester about that program before. I've looked at the data that she has reported back to DCF. And philanthropy and the cost of that program. And it's important to note that model of intervention, when they work with a child and family, that's a 12-month model. The cost rounds out to about $9 a day per family. The cost of a school in one day in response to a children in a behavioral health crisis, calling the police, having an ambulance called, bringing the child to a local emergency department, that one day probably costs as much, if not more, than the cost of providing 12 months of prevention and care coordination and service to a child using that Clifford Beers model. So the price tag sounds big, but when you think about the thousands of dollars that one 911 call led to, that likely did not result in a timely connection to care for that child and family. I mean, we have to look at how we're spending those state and local dollars and how we can spend them to get the results and needs that we want. And I think that Representative Linehan's question also raises a structural need in our state for where we have innovations like that New Haven model, that are funded in part through a state agency grant and in part through philanthropy. Who then looks at the efficacy of that model and helps strategize around sustainable funding streams to support it and to expand it, right? That's something that's missing. And I think it's partly missing because I'm not sure we have the right structure around our children's mental health system to look at and respond to respond in that way to some of the work that's being done and some of the needs in our community. Trying to see if there was, that's the end of my notes. Trying to see if they just look real quick to see if there's anything that I left off here. I didn't, so I just want to reiterate my gratitude for this opportunity, for the work that all of our partners here today, those that work for the state, those that work in the community, to address this. And we are in a crisis, but I think we have better vision because of it. And I think that, and a greater sense of urgency. And we have to turn that into opportunity. And I think there are very specific things we can do. I guess the very last thing I would say is holding ourselves publicly accountable for what we can do in the next 90 days, what we can do 6 to 12 months, and what we can do 12 to 36 months in a very transparent way, measuring success as we go. Those are my recommendations, and thank you very much for this opportunity.
Thank you so much, Ms. Egan, for your work and your help and support throughout this process and some of your thoughts on solutions. We'll move on to our next group of conversations. We will have Commissioner Vanessa Durantes with the Department of Children and Families and her team members to join us. Also, Commissioner Dr. Deirdre Gifford for the Department of Social Services and her team can join us as well. I know Commissioner Manisha Jutani had already spoken earlier, and we have John Fresinelli from the State Department of Education. So as you guys settle down, I just wanted to thank you for your patience and thank you for giving us the time today. I know your schedules had to be adjusted to be here, and I know this is very helpful to us to hear from you directly. And obviously, since we have not met in person for a long time, in the last 18 months, thank you for the work you and your team has been doing, heroic work to save lives, heroic work to take care of the children in some of the most complex situations. We are touching one topic today. There are about 100 topics that we have not touched, and you have both, and your teams have been involved in those 100 of topics and difficult things every single day for the past 18 months. So you're still standing and can smile still. So and our results are there too. So we appreciate you for that. So thank you so much. And we'll have you, Commissioner Durantes, to start. Thank you.
Senator and Representative, thank you. Thank you for acknowledging the fact that this has been a tremendously difficult year and a half. We also like to reciprocate the thanks to members of the legislature who have been in constant contact with the state agencies throughout the pandemic. It has been in little squares, and I appreciate the fact to be able to come here today. I will yield the introductory comments to Commissioner Gifford as a senior advisor on health and human services to the governor to kind of kick off the framework of what we will talk about here today. But thank you, and I appreciate your continued support.
Thank you, Commissioner, and thank you, Senator Anwar and Representative Linehan, members of the committee. We're delighted to be here today. We appreciate your focus on this issue, and I think we're bringing some good news in the progress that we've made over the recent months, and some of the issues and concerns that you've heard articulated this morning. I want to say thank you to those who testified before us. I think it was very helpful for all of us to hear, and brought to light a lot of issues that we will continue to engage with. And like the commissioner, I say thank you back to you and other members of the legislature for your partnership over this, what has been undoubtedly a challenging period of time for all of us. And it's good to be back in this building, even though our faces are covered. It's good to be back in this building and beginning to return to some normal-ish processes. Thank you for deferring, Madam Commissioner. I wanted to just say first and foremost, on behalf of the governor and all of us in Health and Human Services at the agency level, that we are also very committed to working through solutions to this very challenging set of problems. And also getting to the root of what is going on with the children's behavioral health crisis. I appreciated very much Dr. Forster's comments about the nature of the adverse childhood events that in many cases are leading children into a crisis, children and families into a crisis situation. And what we're going to talk about today is some very short-term steps that the state agencies have taken, but we also will begin to discuss some of the medium and longer-term steps that we think are also going to be important. And the issue of addressing adverse childhood experiences and the broader set of social needs for children and families is very much on the minds of the governor and all of the commissioners who are working on these issues. We bring a lot of resources to bear with our various agencies and our authorities and funding, but obviously we can't do it alone. And it's going to require lots of partners, many of whom you've heard from today. So as a few speakers have alluded to, we have brought together all of the relevant agencies to work on this crisis in a very intensive way over the last couple of months. And we needed to do that because the purview of the areas that are needed to address this, this problem rests in many different human services agencies. So you heard from the Department of Public Health. Obviously, they have licensure authority and oversee the emergency transport system, in addition to sort of setting the public health priorities for the state. So that is a critical partner. At DSS, we are a significant payer, obviously, for children's behavioral health services, enrolling providers, designating what services can be covered and how much they will be paid for. The Office of Healthcare Strategy is part of this work because you heard about Certificate of Need, and they are sitting with us as we think about expeditious ways to address this. DCF obviously has the statutory responsibility for the children's behavioral health system, and you'll hear in detail about their work. DEMAS is part of the conversation because so many of the issues are with older adolescents and transitioning to the adult system, and we want to make sure that we don't miss the opportunity to align those systems. And obviously, we work with the Office of Policy and Management on all of this when it comes to funding and policy decisions. In addition to that, we've been working with the Office of Early Childhood and working on, for example, talking about upstream ways to address this, working very intensely on a beginning of a universal home visiting program so that we can begin to get at some of the family challenges that are behind some of this crisis. We're working on a community health worker program with some of your colleagues in the legislature that we hope will be responsive again to some of the prevention and care coordination needs that you heard talked about in terms of connecting people. Working with the Governor's Workforce Council, who is very aware of the behavioral health workforce challenges and working hard to address some of the concerns that you heard about today, in addition to our colleagues from the State Department of Education, who have obviously a huge role in the children's mental health system. So we have all come together, and I just want to make sure that you know that and that the public knows that all of us in these agencies are working in a coordinated fashion to address this issue. And I think that that coordination will be a significant part of our ability to implement these solutions quickly. I also just want to note that obviously beyond the state agencies, there are other key partners, commercial payers, who also have a very significant role to play. As you heard, Medicaid is not the only payer for children's behavioral health services. And so they are a key part of the solution. Obviously, our hospital systems are another key part of the partnership that needs to happen in order to address the multiple layers here. So what have we been doing recently? What have the steps that have been implemented to date? First of all, you heard about this incident command structure that has been set up by CHA, working with state agencies and checking in on a daily basis with the Department of Public Health and the Office of Policy and Management. That was stood up voluntarily on the part of CHA, and that is a place where data about children in emergency departments is being looked at collectively by all the hospitals, and decisions and solutions are being arrived at collectively through that group. And that has been very effective to date in terms of helping particularly CCMC to manage the overflow of children waiting in their emergency department. And we are continuing to talk about how we can continue to gather that level of data and information that is being shared at those daily briefings, so that we have it in the long term to monitor this situation. Department of Children and Families has increased their capacity at SOLNIT. I'll let the commissioner and her team speak to that. At the Department of Social Services, what we have done to date, a couple months ago, we announced a significant rate increase for pediatric hospitalizations. That was a 10% rate increase for inpatient psychiatric services for hospitals that agreed to increase their bed capacity for inpatient PD psych. In addition to that, we have authorized additional payments beyond the 10% rate increase for children with higher acuity. So there's a base rate increase and then an acuity add-on that has been announced. That announcement did result in some inpatient beds being added specifically for children with autism. But no other general hospital beds as a result of that particular offer. So we have, though, been in conversations with other acute care hospitals who are interested in potentially adding acute psychiatric inpatient capacity. And those conversations are ongoing. They're very productive, and we hope to be able to have more information about adding to inpatient capacity very shortly. In addition to that, we will soon be issuing award levels to community-based providers to develop 12 intensive transition care management contracts to improve the throughput at the acute care level. So one of the things that we heard from providers about what was causing some of the slowness in the inpatient setting was the need for assistance with intensive care management to help at the hospital level, getting children, as you heard, set up with community resources so that they can be transitioned out of the hospital. We put out an RFP for that. It's in the final stages of negotiation, and so we will have a joint award from our two agencies on that particular intervention. So those are a couple of the things that have been done. I think they are producing good results in terms of the very immediate acute care crisis and need for inpatient hospital beds. But as you've heard this morning, we recognize, all of us, that adding hospital bed capacity is really not the way to approach a comprehensive solution to this challenge. Although it's necessary, it's certainly not sufficient. And so I'm going to turn the mic over to Commissioner Durantes, who's going to talk about the extensive work that DCF has been doing on the medium and long-term solutions. Thank you.
So thank you, Commissioner Gifford. One of the things that I think is encouraging is was outlined today in the way that you have organized this forum, in that we're not starting from scratch. As indicated by one of the previous presenters, Connecticut has one of the most robust children's behavioral health system. The challenge of that, though, is that along the way, many pieces of it have been fragmented. And as alluded to earlier, the Children's Behavioral Health Plan, which sprung out of Sandy Hook and out of the Adult Behavioral Health Oversight Council, included the development of an implementation and advisory board that has been working on this issue for the last decade. We have seen many advances to children's behavioral health, and from what we all know has been the last year and a half, an exacerbation of not only children's behavioral health acuity and the symptoms of what children are experiencing, but an elevated attention to the collaboration needed between state agencies and across branches. The genesis of our children's behavioral health system did start back in 2012 with the tragedy at Sandy Hook. And so the committed attention to that has developed this children's behavioral health plan that encompasses all of the levels of care you heard here today. It is the goal of the plan to improve the fragmented system with multiple service gaps, to maximize available dollars and efficiencies, decreasing disparities, enhancing accountability, and ensuring a robust data and quality assurance system. The vision of this children's behavioral health plan that we are looking to realize here in Connecticut, and I think with the collective efforts of everyone you heard here today, you've heard the phrase "no wrong door." Well, for families, that has felt like there has been. So we want to make sure that this system can be woven together strong enough to meet the needs of not only pandemic recovery, but the ongoing needs of children and families across Connecticut. And Representative Linehan, I appreciate the emphasis on the diversity of Connecticut's families, and to create a system that responds to our urban centers, our suburbs, municipalities, our rural areas is a challenge, but not one that's not able to be accomplished with the tremendous providers that we have across the state. The accomplishments of the Children's Behavioral Health Plan involves attention to minority and underserved children struggling in multiple arenas, involves working with our education partners and juvenile justice stakeholders, as well as highlighting and emphasizing the need to build up our workforce capacity to work with children with intellectual and developmental disabilities. Our work is very targeted with the Department of Developmental Services. We work regularly with the Office of the Child Advocate to lift up and create an escalation plan if families are struggling. And we definitely recognize that an important part of the Children's Behavioral Health Plan is to increase even more this cross-agency collaboration through fiscal mapping and kind of a service map of what's available across the state. We also have, as a part of some of our medium-term responses from the Children's Behavioral Health Plan, continue to expand access to mobile crisis. And as you heard here today, that is a viable level of care, or at least service intervention, that we continue to refine and encouragely increase. So our ARPA dollars, one of the targeted interventions from our ARPA dollars is the expansion of emergency mobile crisis. There's also recommendations to increase the connections to care. And one of the, of course, medium-term ARPA recommendations is also 12 care coordinators to work with our emergency departments on discharge planning for the families that are being seen in the ED. We also recommend universal use of evidence-based and validated services and screening measures. You've heard our providers talk about the use of evidence-based models, but we also recognize that there are other methods and modalities and frameworks that we have to employ to address some of those other cohorts and affinity groups that we just spoke about. There is a commitment to achieving health equity through promising innovations for the behavioral health system of care. And so all of this was underway over the last decade, and then the pandemic hit. The pandemic hit at the same time of racial unrest and economic devastation for our families. And we heard that if you don't address the social determinants of health through that equity lens, you will leave significant swaths of Connecticut citizens behind. And what we're seeing is, without paying attention to diversity and disparity, there are key communities within our state who need targeted assistance even more. We also recognize that economic devastation that has hurt families will manifest in children and families being under high stress. So what we're seeing in the acuity of the children that are presenting to these different levels of care is a manifestation of the stressors of their families. Many families were impacted by the pandemic, whether it was because of health concerns, or whether or not they had job losses, or whether or not they could just meet basic needs. Maslow's hierarchy of needs say you can't even get to those higher orders of care or higher level orders of functioning if the basic needs are not met. So we recognize that the pandemic has exacerbated all of those things that has then manifested in children's acuity level on the children's behavioral health side. So where are we now? We're at the point at which the state agencies are working much more collaboratively together to address where those opportunities for overlap and funding and braiding, to make the recommendations that we have for the use of the federal funds that come in more sustainable over time. So there isn't a cliff that the state agencies will fall off of, and essentially the providers that we have will be impacted by that. We also recognize the fact that the capacity for special populations that I just outlined sometimes results in gaps in our system. We'd like to close those. We recognize the fact that this urgent care model that we are proposing is as a result of being more fiscally responsible with those levels of care and pieces of the system that aren't measuring to the degree to which their scope is written. So when we have, for instance, a grant-funded group home that doesn't have capacity because or doesn't have utility because there's not referrals to that level of care, how can that be repurposed? We don't want to reinvent the wheel, but we want to be able to be prudent with the use of funding to reshape our behavioral health system to address some of the gaps that we may have along a continuum. So that urgent care level of care is one of those pieces of that puzzle. We also recognize that that along with behavioral health urgent care, the ability to measure outcomes. We talked about the use of data to be able to explain where we are and where we're going. We're working very closely with CHDI and getting recommendations to understand the outcomes for kids and families for the services that we pay for. It's also important that we think about where our statewide data collection sits. One of the things we became increasingly concerned about is we get our data on a daily basis from Beacon Health Options, which is the administrative service organization, but that's only a piece. That's the Medicaid piece of the children's behavioral health system. How do we work more closely with our commercial providers to be able to create that dashboard that looks at the entire throughputs of our system, so we all are informed as to which families need additional services and which parts of Connecticut at any given time. So we absolutely echo the concern for quality data as it relates to children's behavioral health. We also recognize that private and public partnerships are important to support blended and braided funding, but also that accountability piece. So we appreciate the presentations from the hospitals and CHA over the course of the 2 days that you all have put together here today. And lastly, what we will, before I ask members of my team to include any additional details related to the development of the Children's Behavioral Health Plan, its short, medium, and long-term goals, is that we are committed to promoting the well-being of all of Connecticut's children through prevention, early detection, and access to effective services. Now, that prevention is also going to come through our community work that helped to develop the Family First Prevention Plan here for Connecticut, which was specifically designed by including input from 400 separate stakeholders who participated in development of our plan. And many of the folks that you heard here today participated in the prevention plan for Connecticut. We also recognize that a broad array of services through coordinated and integrated system maximizes the available resources that we have, so we're not dependent on one particular funding source, and that we look to empower and support families throughout this process. Families with lived experience are actually families with lived expertise. And we work very closely with families to hear their experiences with the services that are available to them and what they would like to see happen. And that is poured into our Family First Prevention Plan. And of course, the reduction and elimination of ethnic and racial disparities for children and families of color in our state. And so I have with me the Deputy Commissioner of Operations, Michael Williams, who will fill in any additional commentary related to the plan or where we are on children's behavioral health, followed by Tim Marshall, who you've heard from in our Suicide Advisory Board, but also chairs an interagency council related to the immediate needs of children and families.
Good afternoon, Senator and Representative, and I will be very, very brief because the Commissioner was very exhaustive in her presentation and covered a lot of ground in what we're doing. I want to just echo what she said and what others have said earlier today, and that is when you do a national scan in regards to the best children's behavioral health systems in the country, Connecticut ranks among the best. And for context, I think we lose sight of the fact that we have a very good system. And what we are really trying to do is move our system from being good to being excellent. And in order to be an excellent system, we know there are things that need to be fixed. And the good news is that we know what they are. And we really appreciate this moment in time, unfortunately, that it took a pandemic to bring out. But for those of us who have been doing this for quite some time, it is one that we appreciate finally the attention that we as a state need to place on children's behavioral health services in the state of Connecticut. The fact that we have a consolidated system shows that we are dedicated to serving children in this way rather than integrated in adult services where children often get the short end of the stick. Our focus on children in Connecticut is superb. By way of our development, this plan that has been in place that you have approved through the legislature since 2014 and the implementation a couple of years later and annual submissions to you for the progress of it. Members of that plan, well, I would say the architect of the plan primarily were parents in our state who, through exhaustive conversations and focus groups, led to development of what we now see as the blueprint of what they say works. And that is the bottom line. And that is we meet the needs of families and children based on what they say their needs are. And this work that we've been doing over the past decade and at a now elevated level the past couple of years is really trying to assure that the tremendous amount of resources that we already have invested, financial resources already invested in Connecticut's children's mental health services are allocated accurately to meet the needs of families and children based on what they say they are. In the Department of Children and Families, as mentioned, we are statutorily responsible for this, but we know we're not the only agency to do this. And so we're grateful for the support of all the other state partners who have come together to assure that we do this right, giving us good governance around how to go about doing it. And we are grateful for the opportunity to have our external stakeholder partners who have helped us now build what I would consider to be a very robust administrative infrastructure to do this right through CHDI, who you heard earlier today, and through our administrative service organization, who helps us as it relates to fiscal analysis and continue to look at how we reimburse for services. All of that gives us the capacity internally to assure that we implement this plan accurately and effectively. And doing so, I think we're gifted in Connecticut to have one of the great national leaders in regards to public policy around children's mental health, be somewhat the executive of the Department of Children and Families and moving children's mental health forward. And that is Mr. Tim Marshall. You heard him again yesterday when he talked about suicide, but that's only about 5% of his work. This is about 95% of his work here, leading and implementing and being, in a sense, the chief executive of the implementation of children's mental health services in the state of Connecticut through DCF. And so I'll turn it over to Tim and let him give you the final remarks from DCF in regards to the work we've done.
So good afternoon. I think I just would like to just share a couple of things that were mentioned and a couple of things that weren't mentioned. So under the implementation, the children's mental health implementation work, we've continued to be facilitating a number of work groups to continue to put forth concrete recommendations on how to expand and plug some of the gaps in services in the state. Some of those have been mentioned. We're working hard on developing an urban trauma network. The first part of that for Performance Improvement Center has been, contract was recently executed, so we're moving forward on that. We're promulgating very shortly recommendations to the state for the implementation of what we're currently calling a behavioral health urgent care center, but that has many names nationally, but essentially it's an alternative location to send children other than an emergency department. And most commonly their kids are in and out of them within 2 to 4 hours with a crisis assessment and a disposition. You can't stand up one of those without also having a good, strong crisis service array, including the right number of inpatient beds, which you've heard we're working on expanding. A crisis stabilization unit which we're also putting forth recommendations for the implementation of that. Connecticut has a little bit of experience of implementing that and never got fully realized. We hope to be able to put forth recommendations for that. It's a 1 to 14 or 15-day bed for acute or subacute as another alternative to inpatient need. In addition to that, recommendations for crisis respite. Again, Connecticut has some experience with that and pivoting some of the resources that have historically been underutilized to potentially grow out additional alternatives. And then finally, as you heard, the expansion of mobile crisis. And it's not just an expansion of mobile crisis for the overnight hours. It would really also embed and enhance the mobile crisis clinicians with the proper enhancements of the whole system for those mobile clinicians to have real-time appointment scheduling, including being aware of available beds for when there's crises. So those things are some of the areas that we've been looking at and focused on. In addition, trying to put forth alternative payment mechanisms. We've heard a lot about that, but not only a large base increase for services that have been underfunded for some number of years, which you've heard, but also then to change the way in which we fund in order to have full participation on quality around for the full partnership, that is both the public and private partnership of that. That brings with it a lot of anxiety and potential disruption because it changes the way people fund. So there's a lot of anxiety around that. And then finally, the supporting piece is more rapid real-time data in order to make the best decisions for kids and their families. So those are some of the things that we've been working on, but I'd like to name 3 things that the plan also alludes to, which really hasn't been spoken about today. And to mention those 3 things, I'd just like to remind people about the context of the crisis. Before the pandemic, prevalence rates and literature tells us that about 10% of kids in general will have a serious mental health issue, and that in any given year, about 20% will have a challenge that will potentially bring them in the contact of the professional system. Connecticut has 800,000 kids at our last count. That means 80 to 160,000 kids at any time in Connecticut may need services. As you heard, the best systems in the country are able to work with about 40 to 50% of the kids that they have who are in need. And Connecticut is one of those. So before the need of the pandemic developed, Connecticut happened to be in one of the situations to be able to meet about 40 to 50% of the need. Now, one of the things that it's why it may not always be so overwhelmed is that we know that all kids and families who have need don't seek out help. That's a problem in and of itself. And one of the things we saw is that the pandemic exasperated families waiting. They were fearful of going in face to face to get support, and many held on for as long as they could. And I think we're now seeing the effects of that. I've seen 2 or 3 fairly consistent national recommendations on after the pandemic, and since we're quote unquote still in the pandemic, these are difficult estimates. But some people have said that the need has doubled, so that 10 to 20 is now 20 to 40. And I've seen other estimates that say that almost half of all kids are in need now. So no matter how you slice that, we have potentially 320 to 400,000 kids in the state of Connecticut who have need. So that's the context that we're talking about. So in that kind of context, any gap, any challenges is going to be exacerbated. So I just wanted to say that. So the 3 things that I wanted to add in the context of that is we do have a lot of resources. And one of the challenges, despite a lot of efforts, we still remain very fragmented. One of the things that was a very positive outcome of the legislation following Newtown was to recognize that at least 12 state departments share the responsibility in children's mental health. One of the recommendations in the plan of 2015 that hasn't been talked about is really the front door or a single point of access, where you really organize all your services under the kind of a care management entity kind of example. We have an administrative service organization for our ASO. It would be like that on steroids. In other words, you would bring those 12 state departments together who all have responsibility, and be sure there's an entity whose responsibility it is to track every kid in need so that no child or family gets lost in the system. And you'd be able to also streamline data to be able to ensure those needs are being met. So I just reiterate that. Second, you've heard a lot about school. Schools is where it's at. Schools need to have a huge paradigm shift. They can no longer just be educators. They have to recognize that in order to educate kids well, they need to meet student mental health need well. You heard 3 or 4 examples from our providers, all who have done very creative things to try to get in there, but that's not a systemic approach. There is some examples both nationwide and in Connecticut that resemble what the New Haven Trauma Coalition is doing in New Haven with the Clifford Beers, the work that Gary Steck and Heather described in their communities. AWARE is a federally funded project. We are co-supporting that with the Department of Education, and it's a 3-tiered approach, full student mental health integration approach, which divides the student body essentially into all students, those in a middle tier and those in high need. And it takes school climate activities and SEL kind of curriculum activities, the social emotional learning activities, and you put them into a comprehensive package. So you'll be sure that every child, every student in a school who has any kind of mental health need will be on a track to have that need met, whether it's low, medium, or high. And I think that really needs to help happen. And I think schools are recognizing it, but the paradigm shift has not happened. In particular, they don't have a lot of staff with mental health experiences. They have school social workers, school psychologists, and et cetera. But frequently, those folks are often struggling around educational special needs, not mental health need. And the last one I would say is, it's been talked about quite a bit, and it would come with kind of the first one of a kind of a care management entity. But my experience is that we all need each other. And you kind of heard a little bit of different sectors today: the hospital association, the community-based mental health provider system. We all need to do a better job collaborating. And there are times when we don't understand each other or don't speak each other's language, which contributes to misunderstanding and miscommunication. And I think we need to get beyond that. And then we need to add to that collection of partnerships, schools, the adult mental health system, primary care, substance use, juvenile justice, child welfare. That's an integrated group of sector providing. Each of those sectors have their own unique language and vocabulary and a lens which they bring to this situation. We need to understand each other's language. We need to improve our communication, and we need to organize ourselves. My last comment will be, we did a fiscal analysis. We know we are spending a tremendous amount of money already in children's mental health and in the state of Connecticut across those multiple sectors. We need to be better and more efficient about using that money, and we need to put it into a more comprehensive, integrated approach. That's challenging. It's not easy to do. In the meantime, as all those long-term activities take place, we need to continue to do a lot of these short-term quick fixes that you have heard many good ideas, all of which are one small piece of the pie. But in my opinion, there's no real one strong single activity that is going to fix the problem. Thank you.
Thank you. This is actually a perfect segue for John Fresinelli for the State Department of Education.
Thank you, Senator Anwar. Thank you, Representative Linehan. Can you hear me okay?
Yes.
Okay, terrific. Thank you. I'm here. My name is John Fresinelli. I'm a division director at the State Department of Education in the areas of school health, school nutrition, family services, and adult education. I am here on behalf of Commissioner Charlene Russell Tucker. The commissioner sends her absolute regrets. She has meetings right now that she's not able to get away from. That's taking her time. But please know that this is a very front burner issue for the commissioner. It's critical that we work toward providing social, emotional, behavioral supports for students in schools, and that's a critical part of our work. And thank you to Commissioner Durantes and Commissioner Gifford for the collaboration that we have had on the state level with all of our state agencies and our state agency teams. I think if there's a silver lining in this pandemic, it is that the state agencies are continuing to work on a daily and often hourly basis on a number of issues, not the least of which, of course, is behavioral health. I'm going to talk a little bit about the work that we are doing and the work that schools are doing around behavioral health supports and around social emotional learning. As has been mentioned already, this needs a comprehensive solution, right? And schools can't do it alone. None of us can do it alone. We need our state agency partners. We need our private providers, our behavioral health providers, working together on these solutions. So schools are absolutely part of the solution. As Tim mentioned, shifting into understanding the important role that school districts and school leaders are playing in behavioral health supports is critical and is happening. So I'm going to talk about some of the initiatives that have been happening on the state level with regard to this. We started last school year, essentially when the pandemic hit, around conducting a landscape scan with school districts about understanding what were happening in school districts at that time, looking at emerging issues, looking at current trends, looking at some of the programmatic initiatives that school districts were doing in schools to support the social emotional well-being of students. And districts reported a number of things, one of which is that they were working to integrate social emotional learning into academic instruction, which is critical as social emotional well-being is certainly not a standalone, that it's part of the daily work that schools are doing. Most districts reported having at least one part-time or full-time staff person working on social emotional learning. And to Tim Marshall's point, the folks who are working in school districts, school counselors, social workers, psychologists, have a lot of responsibilities, and certainly behavioral health is one of them, but certainly not the only one. Districts reported a number of activities that support student social emotional learning, but also support adult social emotional well-being as well. They talked about having lessons that they provided in classrooms for schools and providing professional learning related to social emotional learning. But one of the critical results of the survey that was reported was that school districts weren't necessarily using a needs assessment to drive their initiatives to support students and to guide their implementation. So that is directly in line with the legislation that passed last session with regard to school districts conducting their own social emotional needs assessment. And as a result, the Department of Education procured the Devereaux Student Strengths Assessment System, which is a social emotional assessment system that looks at student strengths. And teachers use this tool to assess the degree to which students have demonstrated specific social emotional skills. Excuse me. So some of those are things, or some simple things around self-awareness, about social awareness, about responsibility for self-reliance. And the DESA looks at how well are they working with others? Are they working well and collaboratively in groups? How often did the child try to help someone else in class who was struggling? How well did they interact with their peers? In these ways, we can have teachers build on those student strengths and work with families to develop these capacities in our students and thereby improving their social emotional well-being. Currently we have over 60 districts that are participating in the DESA. Our first cohort rolled out last month. And to date, over 36,000 students have participated in the DESA assessment. Recognizing the need for social emotional wellness for our staff as well as our students, we are using, folks were talking about the use of the state level ESSER and American Rescue Plan funds. We are using the ESSER 2 funds to support something called EdCert, which is the Educator Social Emotional Reflection and Training. This is a professional development program for school leaders to support their own social emotional knowledge, their skill set, and wellness. And again, we're doing this because we know that for our educators and for our school leaders, in order to assist and support a student's well-being and behavioral health, they certainly have to be in an emotionally supportive place on their own and understand and have their own positive social emotional well-being. That will be rolling out. Also, several years ago, we developed the components of social emotional intellectual habits for grades 3 to 12. We're in the process of rolling out a similar companion document for grades 4 to 12, integrating social emotional habits into content areas so that students can practice and learn these social emotional habits and continue in supporting their academic and developmental growth. Earlier today, Alice Forrester actually mentioned the importance of or the issues around chronic absence with behavioral health. Absolutely true. We know that often students who are chronically absent are not necessarily always suffering from physical ailments, but behavioral, mental health ailments as well, which keeps them out of school. Back in April, the State Department of Education, in collaboration with the Governor's Office and our regional education service centers, rolled out what we're referring to as LEAP, which is the Learner Engagement and Attendance Program. And what this is essentially a home visiting program, often with parents and teachers, a parent-teacher home visiting collaboration, in which we're working through the RESCs with over 200 home visitors who are going in to visit families in 15 of our priority districts. And the students that they're targeting are the ones who have been disengaged the most in this past school year, who have had the most attendance issues and are suffering from chronic absence. So to date, we've the home visitors have conducted over 6,000 home visits with over 2,200 families. And when they visit, they're talking about everything from, are there behavioral health concerns? Are there mental health concerns? Are there access to healthcare, including social, emotional, and behavioral health issues? But also, are there issues of technology support? And are there other issues, social issues that our home visitors can support our families in doing? And that's continuing through not only happening all through the summer to gear up for attendance in this current school year, but also throughout the school year to make sure students stay engaged. So in addition to the landscape scan for social emotional learning, we launched another survey with districts to understand their needs with regard to behavioral health services. And we are working closely. This is one of the wonderful partnerships with our Department of Social Services and Department of Children and Families. Folks were talking about the use of ARPA funds, and we had talked about the use of ESSER funds, American Rescue Plan funds, to support this work. And so we've had many conversations and a lot of discussion with our partners at DSS and DCF, and certainly our behavioral health providers, Clifford Beers and Wellmore and others. And CHDI has been a huge partner, and also the Village, all of which you've heard from today. Right now, we've got a significant amount of resources in districts, right, through the ESSER 2 and ARP funds. And so what we want to make sure is happening is, if we're setting up systems of support for behavioral health, and that is happening, and I'll talk a little bit about that a little bit later, how do we use this time when the resources are in place to set up systems of support so that beyond the investment of these federal dollars, we can continue to support financially with resources, support behavioral health in school districts. And we're talking about how do we structure and how do we work with our Medicaid partners to utilize Medicaid funding to support that work. There's been a lot of discussion today around the reimbursement models and things like that. And also, I think Commissioner Gifford mentioned the Office of Healthcare Access, have had conversation with them about using private insurance dollars to support this behavioral health. So this gives us a wonderful opportunity to do some pilot work and to be able to sustain it long term through those other funding mechanisms. During this time when students are experiencing trauma, it was also mentioned, a lot of students experiencing trauma, both low-level chronic trauma and acute trauma. We want to make sure that schools understand that that's happening with students. I know Sarah Egan has been, we've been in a lot of conversation with the Office of the Child Advocate around some challenges that schools are having. And so a number of other entities, including the work that we're doing around juvenile justice, and talking about how do we make sure that school districts are engaging in restorative practices in lieu of exclusionary discipline. We want to make sure that students who are suffering, who may be acting out as a result, are not sent home from school, right? We want to make sure that we provide some wraparound services for those students and work to make sure they're continue to be welcomed in the school, and that they have adults in the school buildings that are supporting them and able to support their families as well in their work. There are a number of trainings happening this year, literally dozens of trainings that have happened over the past year and continue to happen with our partners at the State Education Resource Center and others around culturally responsive family engagement strategies, around multi-tiered systems of support for school-wide behavior support, around teaching and leading schools in times of trauma, the impact of childhood trauma on students and learning, resources to support students with additional needs, special needs, as Sarah mentioned as well, making sure that we're supporting those students and families as well. And we talked about how programs get implemented in school districts. Representative Linehan, I know you mentioned taking off-the-shelf products to be able to implement them in schools to support that work. One of the things that we look at, and we help districts look at, is something we refer to as implementation fidelity, implementation science. What are they current? This is the purpose of the landscape scan and the behavioral health scan. What are they currently doing? How is it working? Do they have the resources to implement something else? And will they have the ongoing long-term resources and motivation to continue that work? How does it fit with what they're already doing? Not just dropping a program in and seeing if it works, and then if that doesn't work, try something else. It's really looking at and creating systems of support and systems of implementation around this work so that we get the outcomes that schools get the outcomes that we're looking for, which is improved, emotional wellness for our students and our staff. A couple other things.
Would you be able to wrap up if you could?
Sure. Yep. I think I just wanted to highlight the collaboration with the Department of Public Health, and I'll close with that. The work that we're doing around ensuring that students have access to in-person learning is a critical part, and our partners at the Department of Public Health, we're in continuing conversations with them to make sure that students are safe and healthy. But we know that both academically and emotionally, students are better off in the school classroom and with their peers and with their staff. I'll just, if I just could close with, I know Sarah Egan mentioned the importance of having pro-social activities for students, and we certainly recognize that. The department, through a number of sources, both state funding and federal funding, have continued to provide tens of millions of dollars to school districts to provide after-school and extended day programs to make sure that students have both a place to go and things to do, but also those create opportunities to engage in behavioral health, additional behavioral health supports with adults and with providers. So Senator Anwar, I apologize, I went a little long, but thank you for the opportunity.
Thank you so much. Thank you. Truly appreciate your time and detailed perspective. I do have a few questions, and then these are hopefully short questions, clarifying questions, and then we will have questions from with all the people joining us after Representative Linehan has an opportunity to ask as well. One of the questions, commissioners, I asked was rate of increase of the 10% that you use. What is the date for that?
Senator, I know that we issued the policy bulletin probably in July from DSS. So whether the exact implementation date was August 1 or September 1, I don't know the exact date, but we did issue that policy bulletin several months ago.
So it's implemented already?
Yes.
Perfect.
And we can get you the exact date.
And the other question wanted to clarify was the date of the mobile unit increase funding and then the plan. Is that implemented or is just in conversational level?
That's in works. It's not been fully implemented yet.
And do you have a timeline if possible?
Yes, we'll be implementing amendments hopefully in the next couple of weeks.
Weeks? Okay, yeah. Excellent. And the 12-bed increase that we are talking about, do you look at the timeline for that? Do we need DPH approval? Would that require CON?
Yeah, so are you talking about state bed capacity or private bed capacity?
That's my next question. Actually, maybe we can combine the two because there's probably a opportunity for Solnet to have a public-private partnership opportunity there. Is there a timeline for some of those things?
So for Solnet Hospital, so of course, because Solnet has a PRTF and a male PRTF and a female PRTF, for Solnet Hospital, we were able to adjust some of the COVID restrictions that we had there to try to keep the transmission rate, and we were very successful at doing that. We were able to admit 7 children last week, and talking to the superintendent this morning, we can increase that to another 9 kids over the next week or two. But you also want to pay attention to the balance of the milieu, but that will have a significant increase at the state facility.
So
Okay.
16 state beds on the hospital inpatient level of care. And then on the private provider side, I can't give you a date yet on when those bed expansions will happen because, as I mentioned, we've gotten requests from certain providers who are asking for support that looks different from what we already issued in June and July, and we're having active conversations. We hope that those will be wrapped up very soon, but I don't have a date certain because it's not completely within the state's control.
Thank you so much. And another question, what can we do immediately and long-term for the workforce recruitment around this? Any thoughts? I know we had a brief conversation with the DPH commissioner and she looks at this as her priority as well, and I'm sure it's governor's priority too.
It is, and so much so, oh, excuse me. It is, and so much so, he has directed the workforce component of any requests that we had either through ARPA or our general concerns through the Governor's Workforce Council, which has now been created as its own standalone entity. So that's the group that Kelly Valeris oversees, and there's this component of that for human service workforce issues, which encompasses all of this, public and private.
Yep. So there, yeah, just to add to that, there are training enhancements that we're looking at. And I say we, but I mean in partnership with the workforce, the Governor's Workforce Council, whether there are training slots that could be enhanced, whether there are anything that we can do around licensure and certification, as we talked about earlier. This issue of exams, I heard when I was at DPH, looked into it at the time, and there were no capacity limitations or restrictions on examination. So I think we need to get to the bottom of that, because we're hearing different things from different parties. And then, the issue around compacts and licensure with out-of-state providers is something else that's on the table. So part of this interagency process that we described earlier, this workforce development piece is on the agenda, and we're working through sort of timelines and project plans for all of those things.
Excellent. And I want to clarify with respect to the ARPA dollars, any specific focused area that you think we would get the highest ROI long-term without a cliff? I think you touched on it, but
every single one of the recommendations that we put forward had a sustainability piece, whether that was through mental health block grant, HRSA funds from the federal government, or whether or not they could be considered for Medicaid. So I feel pretty confident that the ARPA recommendations have that sustainability. Would you agree?
Yeah, I mean, the mobile crisis clearly is Medicaid fundable. So we'll have a little plus up around mobile crisis in the short term, but then we'll be able to work on funding that sustainably for those individuals who are covered by Medicaid. And that's why I mentioned, that working hand in hand with the commercial payers is also going to be important. And then the mental health urgent care should also be easily a Medicaid coverable services for a sustainability plan. I just did want to mention, because you asked about CON issues around increasing on the private side. So far, we don't think that's going to be an issue, because the hospitals that we've been talking to are talking about working within their already existing licensed bed capacity. So we don't think that there will be CON issues, but we do have OHS at the table as part of our multi-agency work group, so that they can advise us, and if we're getting to any issues around certificate of need with some of these requests.
thank you so much. There's a question that I wanted to ask, and I'm going to ask it. We talked about the 12 or so agencies that are looking at children's mental health issues in our state. When we have the disjointment concern is that DCF says that I am taking care of this part, and they are expert in one area, but they may not be an expert in the inpatient part. DPH says, well, look, this is children's issue. We are not necessarily hands-on on this one. It's almost like there is a concern from the outside, since I'm not in any of those conversations, is that there's no leader in the group who says, well, this is going to be my area and I'm going to be taking care of this issue. And not only in advice, but governance. In other words, the buck will stop at somebody. I don't know who that somebody is for children's mental health in the state of Connecticut, while we have 12 or so agencies at the table. And what can we do about it?
So I appreciate that framing, because DCF has the statutory mandate. However, we can't compel our sister state agencies. I think the role that Commissioner Gifford is now in, advising the governor related to health and human services issues, is getting closer to that infrastructure concern that you raised, because she has convened not only a landscape analysis of what is happening under the Children's Behavioral Health Plan, but all of the other ad hoc groups that have also sprung up as a result of some of the urgent need. And I do believe we are getting very close to being able to identify just that point person. I made reference to an interagency council that Tim is chairing, and I believe that's the role that you will start to see more and more of you in.
Yeah, Senator, I think you have touched on an issue which is not unique to children's behavioral health in Connecticut. I mean, we are sort of set up statutorily to have human services responsibilities divided over a number of state agencies. It's a long-standing issue, and it's not unlike many other states. It is, the governor has recognized this as a potential barrier to providing optimal services to the people of Connecticut and to having the most efficient way of managing our human services infrastructure. So I would say that he has asked us as human services commissioners explicitly to coordinate around not just this, but many other issues, substance use disorder, adult behavioral health, COVID. There's a fairly hefty list, early childhood issues that we are meeting on a regular basis, convening and working to identify and overcome those barriers. So we may not have the statutory framework where you could point to a single person and say you, but I think we do have a functional framework that we've put in place that is helping to overcome some of those challenges.
We will have hopefully another roundtable conversation around the legislative solutions. I think that's been requested. I think that's in the works. Do you think that the issue that we just touched on, is there a legislative part to create, and we don't want to create more offices because there's a cost associated with it, but again, we need somebody to say that the buck is going to stop with them, and then knowing the workload that you are all handling, because I'm privy to some of the other things that you're doing, it's going to be that last thing that's going to break the camel's back, if you will, right? That's the fear that I have, but you're handling it, but there's somebody who has to own it, and then own it comprehensively throughout the spectrum. And would love your guidance if there's a legislative solution to this. We are very much on board to help out in whatever way we can, but we recognize and we are fearful of losing this opportunity to have a comprehensive strategy, so we never have to have conversations about this concern. We just have celebrations that we are taking care of our children.
Understood. I think it does merit further conversation. I will say that just if what you're suggesting is an additional office for children's behavioral health, I would say that my first reaction to that is that might be duplicative and unnecessary. I think most of us feel in the human services agencies that this problem belongs to all of us. I understand your impetus and your desire to say where the buck stops. But on the other hand, I think that it is a core part of the mission of each one of our agencies. Certainly it is at DSS. We are the largest insurer for children. We probably are the largest payer of children's behavioral health. Obviously, statutorily, it's core for DCF. DDS has a huge part to play, OEC, and for each of us, that's a key part of our mission. So look forward to further conversations about that.
Thank you.
Senator.
Thank you so much. And Representative Linehan had some questions too. Thank you.
I do. Thank you so very much. First, I want to begin by saying I want to thank you all for the work that you're doing. The pandemic has been tough on everyone, but especially our children. And I want to specifically thank you, Commissioner Durantes, because I've been in touch with your agency often throughout this entire mess. I'm going to call it a mess because that's what it is, right? And so I'm calling it that because a lot of the efforts have been to clean up the mess. That was like out of our control. And now we're trying to put things back together, right? But what we've talked about today and even yesterday, and I don't know if any of you were able to see part of the program that we put together yesterday, we've really come to learn that the focus often has been on EDs when that is really sort of the middle to the end of the line. So my questions begin with Commissioner Gifford. You said that you were looking at a 10% increase for places that add beds. You're doing all that, but that's focusing on the ED side, right? So we appreciate that. Once again, it's trying to clean up the mess that COVID created, because there are an increase of children who certainly need inpatient services. But we need to still remember that there is a much larger group of children who need those outpatient services. So what do you have in store besides, we'll get to the urgent care centers. I think that's separate. But do we have ARPA dollars going to these community-based outpatient programs to support the first stop for children and families when they are having a mental health concern outside of crisis and mobile crisis?
Go ahead. Yeah.
One of the other ARPA, excuse me, I didn't want to interrupt Dr. Gifford, but one of the other ARPA recommendations has to do with increases to access mental health. And we got a little bit on that. Well, I can't remember who was speaking when they talked about access by pediatricians to consultation for behavioral health services. And that is one of the also medium-term ARPA recommendations, as well as the mobile crisis that we've been talking about a lot here today. But we have been addressing, I believe, the short term, which is the decompression of the emergency rooms, the medium term, which would be the ARPA recommendations. And in my mind, I bucket the longer term full, soup to nuts and the children's behavioral health plan under the plan. So, we are kind of thinking of it for the long term and not just addressing the behavioral health crisis in EDs. But that was kind of what got our attention in the public-private partnerships with CHA.
Yeah. Right. So I've been a huge proponent for access mental health for a long time. And it is actually not very expensive to beef it up. Let's be honest. It's really just getting more people available for emails and phone calls and those and to be consulted on these issues. However, there's something I just want to throw out there. Access mental health, I think that it needs an infusion of money, indeed. I would like to consider the ability to not only have it be a consult for a pediatrician, but to also be an area of service for pediatricians for continued training for those pediatricians. Because I think of it this way. We just spent an hour yesterday telling people to start with their pediatrician. And if the pediatrician doesn't know what to do, they can call Access Mental Health. But then there's that gap there that says, okay, call Access Mental Health. And Access Mental Health could say, for this particular case, I think you should do bop, 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 bop. But in addition, here is this training program that we can have, that we can administer to pediatricians. I think that having Access Mental Health is really great, but we also have to consider training our pediatricians to not need access mental health so much. Does that make sense?
Yeah, it absolutely does. And that is a both and, the increased capacity for consultation, but also behavioral health integration in primary care, which will increase the capacity for primary care providers to do routine behavioral health conditions that they can identify and, start the process without having to kind of refer out to someone else for consultation. That is a piece of the system's response.
Excellent. And then back in June, I spoke with the Office of the Governor, who had asked just kind of casually, if you can have your best shot at some things we could do now, what would it be? I did mention care coordination. So I was happy to hear that that some of this money is going to care coordinators. But I'm wondering, is that implemented already?
So that we're in the final stages. We did an RFP sometime back in the summer. We've reviewed the application. We had a number of qualified applicants, and we're in the final stages of reviewing and being able to get those contracts out the door. So we're very close.
Excellent.
But that, we're at the final stages of implementing.
Excellent. And so this implementation, because these programs are really great, but I always find that not everyone knows about them. So if a child is having trouble in school, and the school might know about these care coordinators, but what about the parent that's sitting at home going, like, I don't know what to do next? Because that was exactly what we were talking about yesterday. And we're trying to get that information out there. Are there any dollars going towards direct conversations with parents on how to get their kids into care?
We are making a significant investment in parents through our parent organizations, not necessarily through the ARPA dollars, but through the increased dollars we received from the mental health block grant. That gave us an opportunity to expand our capacity of supporting our parent organization called Favor. And it's through that organized agency and the many parents that serve there as peer-to-peer support staff and other capacities that we're able to get a full amount of communication going to parents.
How?
You want to talk about how? Go ahead.
Sorry, I didn't mean to interrupt. There was one other activity that we're also doing. The information that we actually provided for you for your support yesterday. There's a website that's been under construction for some time called Connecting to Care, which is specifically made and built for families. We're building a decision tree matrix so that they can go on with, here's my kid's symptoms, and then they answer a series of questions, and the end of it says you could use this treatment or this treatment or this treatment. It makes recommendations. So that has been that information that we passed along to you yesterday, that's posted there now, and we'll have a description of pretty much the full behavioral health system. Again, that's in progress. And then there will be this decision tree matrix that would also help families understand which would be the best services for them. So there are and there are other websites. That's not the only one. So there are.
Which is fantastic. And that amount of information was tremendous. And for the members of the committee who are still on this, please remember that we did pass into law that that information that you were talking about needs to be given to every child that visits the emergency room for any reason. Broken leg, they're getting information on how to find mental health help in their area. However, we wrote that law so that we're meeting children where they are. So I guess the question is, this is great that you're doing it and I love it. Are you meeting parents where they are? How are you getting that information out about that website? Is it going through schools? Is there a marketing program, a social media program, a television ad campaign? How is that happening?
Yeah, all of the above, actually.
Great.
And most primary, again, what Deputy Commissioner Williams referred to as Favors, our primary family organization, but there's also other family organizations that we've all promulgated and continue to promulgate. There is a number of videos that have been developed, particularly around suicide prevention, which has the branding of where these resources can be gained. And there's also some plans in the works for additional kind of outreach activities.
But do I need to be involved in that parent organization in order to get this information directly to me?
No, I think that the challenge is that no matter how broad you are, you don't get to everybody, right? I mean, we try really hard to do that, but if there's suggestions or ideas about where we could go to bring in, we would be happy to do that. But we have a number of avenues that we have been exhausting for some time, including social media outreach also.
Great. I'd love to be part of that conversation. Thank you. And I guess this question would be for Commissioner Durantes, or even back to Tim, if you will. Both of you were talking about the urgent care model. This is fantastic. So we've been talking about this between ourselves, and is this the first public confirmation of this that you've had so far?
thinking about how we utilize, this is one of those areas that we've talked about, the stretch of the ARPA dollar and how we can target and reimagine some of the existing resources to fill in these gaps of other service types that would be helpful. So I would say that it is, we have been talking about it in concept, and urgent care means something different in the healthcare space. And so even refining what it will be called, the scope of that service, and how it will be funded beyond the ARPA dollars is what gets the attention of the work group that's working on that. And that's, Tim
Sure.
can talk about the details of that.
But when both of you spoke about this today, there was no mention of a timeline or number of locations. Can you speak to that?
So those are part of the recommendations, and part of that literally is connected directly back to finances, how much will be available. And we have kind of multiple levels of recommendations. So there's the full model, which is an expensive model. And again, as soon as you start talking about brick and mortar and siting, obviously there's more time consumed in that. Can you stand up parts of the model with existing within available space, et cetera? So that's a potential alternative to that. And then how many across the state and where would they be placed? Those are all things that will come forward in the recommendations, but the basic foundational recommendation is building a location for kids to have a crisis assessment that's not the emergency department, and that there will be supportive legislation that would allow for that to occur. So those are all ideas in play. I think you heard Gary Steck make the recommendation about, again, maybe standing up part of that, utilizing mobile crisis and ECC's enhanced care clinics as a step in that direction. So those are lots of things. So kind of you have this continuum of possibilities in terms of the recommendations coming forward from beginning that all the way up to this, envisioning a brand new standing free location that would be that.
Right. So I'm glad you explained that, because it sounded like this was more of a midterm response, when in fact this is sounding like it's actually longer term. It's not shovel ready. It's not ready to go. It's not going to open its doors to its first child in the midst of what we're seeing as the crisis.
Yeah, we could potentially go to RFP within, by the springtime. My point is, though, regardless of that, we don't know the scope of who could be able to do what and when. So again, we're kind of moving from the model and the recommendations for that, and then what alternatives would be in place or offered within the context of moving that forward, including and up to the RFP for procurement for it.
Which brings me back to the fact that, while this is fantastic, it does take a while. So we need to remember to put money in places that are already open, are already seeing people, are already going, right? So we are now in this position where we're like, okay, we're weighing our money. Are we going to be putting it towards the longer term and neglecting the shorter term? We absolutely can't do that. And I think that we're back to, again, another step back in the conversation, where it's about the community-based services that are outpatient, that are the intensive outpatient, even partial hospitalization. Waterbury Hospital, it was either an IOP or a partial hospitalization, was closed in the middle of the pandemic, when we're having a crisis of epic proportions for our children. So that was, I don't know the circumstances surrounding that. But it's very, very, very bad timing. So I just want to, I think that for the foreseeable future, where my advocacy is going to be for these community-based services that stop our kids from going into the EDs in the first place, rather than primarily focusing on more bed capacity, because if we can do the first, we're not going to need the second.
Representative, I think we are all on the same page about that. When we sat down to look at how to tackle this issue in the short term, there was a little bit of order of battle that we needed to triage, and we had an immediate crisis of emergency department overflow that could not be ignored. So, we implemented, worked with CHA. They stood up the incident command structure, and we're working on the throughput. I hate that term, but the throughput, so that we don't have children and families lingering in the emergency department. At this point in time, that's going to take more inpatient capacity. So the order of battle was, let's figure out how to address the immediate crisis. That's going to take some more inpatient capacity. But every single agency working on this issue agrees with you that the solution is not to just build more treatment capacity for the very most severe, because we don't want children and families to get there, obviously. So we agree, and part of the work that's being done through the Children's Behavioral Health Plan and the committees underneath it is to identify where those gaps are, what we need to do with respect to funding, rates, et cetera, and then work quickly to make those things happen to the extent that, we obviously have to work within our budget and work with OPM, et cetera. But nobody, I just want to reassure you that we are not neglecting those pieces of the system. They're very much front and center, but we're ticking through the most urgent pieces right now, and then we're also simultaneously working on getting those other things on a sustainable path.
Great, thank you. And I just want to say that both of you have earned my respect a great deal. I appreciate all the work that you do, and I would be honored if you were to come to this committee and let us know how we can assist you in that. We're really on board, and we would really like to help you with that. And I just have one final question, actually, for John Frassinelli. Is he still with us? There you are. Hi there.
Hi.
Hi. So I have a question regarding chronic absenteeism. Yesterday, we spent some time talking about school aversion, and I think school aversion is not necessarily the same thing as chronic absenteeism, but the two absolutely go together. In 2017, we removed truancy and defiance of school rules as a reason why a child can be referred to the juvenile justice system. In its place, we put that schools should refer children to the youth service bureaus. Unfortunately, then we failed to fund youth service bureaus, and they're not in every community anymore. So now we're looking at children who have an increase in depression and anxiety and mental health issues that often become school aversion issues. We don't really have a place to send them. But here for the last 2 days, we've been talking about the wonderful service of mobile crisis. So we don't have, first of all, I don't even know if we have truancy officers as they've been in the past, because it doesn't go into the juvenile justice system. Thank God, that was the right thing to do. But now that we also don't have the capacity in the youth service bureaus, should we now be considering looking at chronic absenteeism and school aversion through the lens of sending a mobile crisis?
Well, thank you. That's a great question. And I think
Could I just interrupt you? I'm sorry. I do apologize. I have to leave at this point. So if there are any follow-up questions for DSS, I'll be happy to get them through my colleagues. Thank you again for having us and giving us the opportunity to speak.
Thank you so much, Commissioner. Thank you.
Thanks, Commissioner.
Sorry, John, go ahead.
No worries. So a couple of things. I think Gary Steck from Wellmore talked about this sort of reutilization of mobile crisis, right? So mobile crisis is, but we don't want folks to call 911. We want them to call 211 for mobile crisis. And what Wellmore was talking about in Waterbury was using mobile crisis as a less of a last ditch implementation to support students and think about supporting them, being able to support them emotionally. So I think that conversation around how we sort of rebrand what mobile crisis can support to schools is part of that. I think the work that we're seeing with the learner engagement and attendance program through the LEAP program, the best practice models around parent-teacher home visiting. A lot of districts are doing additional work in addition to the 15 districts that are working on through LEAP. Districts are having their own, standing up their own programs around home visiting to get at exactly what you're talking about. What are the barriers to having those students come to school, and how do we provide those wraparound supports? Again, whether they're technology or behavioral health or finances or transportation or otherwise, how do we support those students? And I will say that youth service bureaus are still on the table. I think there are 104 youth service bureaus that cover about 150 different communities. And I know Deputy Commissioner Williams and his team are working with youth service bureaus to provide all kinds of levels of support, not just for truancy, certainly, but all around, positive youth development and leadership and additional services. So I think that is still on the table. In addition to that, in schools, we have school districts have a number of attendance liaisons. We work with them directly. We've stood up communities of practice with our districts with the highest absenteeism rates to do what had been talked about today about sharing best practices about making sure students are engaged and connected to schools. And then finally, to your point, the school aversion question is a big one, right? So we're making sure that students are connected to someone in the school building. They have an adult who cares whether they come to school every day or not, and they're working, they have a curriculum that's engaging, and they have things that they can do either before school or after school or during school that makes them feel engaged and a reason to come to school, and making sure that those environments are welcoming and supporting. And I think all of those have to be working together in supporting our students maintaining regular attendance, because that's the key, right? Regular attendance is the key in order to understand those scaffolding subjects.
Right. I thank you for your answer, and I'll just leave with this one thought, that when we think about truancy in years past, it's almost a word that means kids who don't want to go to school. When we talk about school aversion as it relates to depression and anxiety, it's kids who can't go to school. There's a difference. So we need to focus on that difference right now. And that's really what I'm looking at. I'm not talking about the kids who would rather skip school and hang out and do what we did in high school and just maybe skip a class and not go and have an unexcused absence. I'm actually talking about the kid that can't physically get themselves out the door because they're so terrified, because that's happening. We heard from Ben Shaback from Cheshire Public Schools, licensed clinical social worker in the schools, that school aversion has almost doubled in Cheshire alone. That's my town. And I'll tell you what, that's my kid. I get it. So it's not that they don't want to go to school, it's that they can't. And so that's why mobile crisis is important in that situation, because we're not talking about go to the youth service bureau, stand in front of the YSB and talk about why you didn't go to school, and that perhaps maybe if you were involved in sports, it would be a good thing for you'd want to go. I'm talking about like the kid that says, I'm afraid if I go there, I'm going to die. And that's what we're talking about in terms of mental health. So I recognize what you're saying, and in your lane, that is exactly right. I'm talking about now in the lane of the mental health crises that we're seeing today. And I see Commissioner Durante's bobbing her head. Yes,
I'm sorry.
you. We do that to each other a lot, but yes, please.
We do. And I just wanted to echo appreciation for that, because I think that, one of the things we started with by kind of talking about the crisis that families have endured over this last 18 months, around every corner was an uncertainty for a child. And that uncertainty is now manifesting in the either generalized anxiety, or whether it's school aversion, or whether it's, separating themselves from their friends, whether or not it's fear of COVID. All of those things are very real. And I appreciate you articulating it in a way that really just kind of elevates what we're in right now, because this is not going to go away very easily, but it's the continuation of public-private partnerships and the full continuum of care addressing all of the different communities within Connecticut.
Thank you. It's money, money, money. Senator.
Thank you so much. May I ask all the presenters and panelists who are here right now to join us again for if any of the people have any questions from our committee? And I cannot thank each and every one of you for the time today. I can tell you the results of our conversation will save lives, improve the quality of lives of our children. And you have brought about information to the community that is hungry for understanding. Our legislators across the state right now are asked questions and they don't know what to answer and how to answer, and they reached out to us. And many of the parents are reaching out to us for these as well. So when everybody here, I want to see if there's any question, and I see Representative Foster has a question. So Representative Foster, please go ahead.
Hi, thank you so much for putting this together, to the chairs, and thank you to all of the state agencies and advocates who are here today. I'm really grateful for the opportunity to listen and learn to you all, from you all today. One of the questions that I have sitting is, what are our opportunities right now to streamline some of this work or accelerate pilots that might be effective at quickly intervening in areas that might be seeing crisis in higher rates than others or might be underserved? I'm thinking of, for example, the pilot examples that Dr. Forrester had talked about. Are there things that we could be accelerating? And then sort of a second question as follow-up, that we have a lot of academic institutions that are sort of influencing and forming the next generation of interventionists, but also scientists. Are there other academic institutions that have been reached out to? Are there promising interventions that we could be scaling up and out with an academic public sector partnership that also might offer opportunity? And I think that that's probably something that could be considered, like with DCF partnerships with schools of social work and school partnerships with academic institutions that have future teachers or EdPsych. I'm thinking like UConn has programs that could probably offer support in a lot of different arenas. Is there room for collaboration there that might help us stem this epidemic a little bit? I don't know. I defer to the chairs to who would be best to call upon for answering those questions.
I think, go ahead, Ms. Commissioner, sorry.
Yeah, my response is to the second part of the suggestion, which is a good one. Many of the organizations represented here have partnerships existing with the schools of social work and other different disciplines. And a lot of the workforce issues would be worse than they are if we didn't already use kind of interns to kind of cultivate some of the next generation of workers. But I think, I think that fits squarely in the workforce development piece, because there are existing partnerships with many of the universities, not just here in Connecticut, but those that are right over the line. And I know that many interns are placed in all of our facilities.
Thank you. Dr. Forrester, yes.
Thank you, Commissioner. That's exactly right. But I also want to say that we've been working at Connecticut Health and Development Institute, UConn, and many other organizations have been working on a school-based mental health group and committee for the last 3 to 4 years, 5, and have really vetted lots of different school-based models that is pretty highly recommended what we want to do going forward. And perhaps Jeff can talk more about that.
I'll just make a general response to that and say that I think that the need isn't necessarily that we need to come up with any new models. I think we have a number of really good models that have been researched and vetted in the literature, but also tested out in other states. I feel like sometimes the issue is that we don't scale up what we know works. So we know what works. There's a number of things that are already in place. The question really is, how do we leverage the resources we have right now to scale up things that we know are effective? And I believe that we know what those things are, many of which you've heard about today.
I'm just going to try and see if I can tease this out.
Can I ask? Oh, sorry.
Yeah, no. I think what Dr. Foster or Representative Foster was alluding to probably is, and you can correct me if I'm wrong, is that we have pilots that have worked, and I think you confirmed that. And then there's a gap where the pilot has shown that it's effective. It's going to save, do the well-being for the children, save us money, and then the return on investment is going to be appropriate. But then there's a gap because that pilot never becomes a policy. And then how can we bridge that gap? Representative Foster, did I say it right?
That captures it well. And I think, it would be helpful to know specifically where things are getting held up from executed in policy level. Is it legislative policy that's needed? And if so, like I would love explicit direction on that. But if it's internal organizational and systems policy that can be happening from agencies, what is holding folks back on doing that? Because I think like there's a lot of evidence in this space about CHWs being effective in a low cost intervention. I know what the policy barrier is to that. And I hope that we can address that in the coming sessions, because that's something that is a barrier to lots of health-based interventions. But, like, is there like like what can we do to support that sort of acceleration and scale up? So we've identified, we know what the intervention is, we're not getting to scale up. What do we need to do make that happen?
I'm going to age myself here, but I've been around long enough to remember when we piloted things through SAMHSA grants, ACT teams, mobile crisis teams, and when we had the data that they were successful, we would go to the legislature, the appropriations committee, ask for funding to do it in a statewide way, and that's how we spread the program. So I think there is an opportunity there to take the pilots to you and to others for funding, because historically, I'm going back, but historically, that's what we used to do.
So I think that brings it back to the legislature then. Okay, so we need to know about these pilots. What's one-stop shop to learn about all these pilots? Yes, Tim.
Well, you heard earlier from quite a bit that the existing programs has been flat funded or underfunded for 10 years. So it's hard to bring forth innovation when that's occurring at the same time, I think also. So it's part of it. I've been around a long time also, and I've seen at least 3 major fiscal crises and a number of small ones, and human services and children's in particular took big hits during those. I've been around when there's been very robust surplus and very little additional spending in human services in general, and specifically children. So from my perspective, there should be and could be opportunities, but it's hard to think that way when just the basic system wasn't funded.
Yeah. For some of the other things that we are doing, I can tell you when I was chairing the housing committee for prevention of homelessness, we had one of the best system in the country, except we stopped funding it, and then it became less effective. And then we said, oh, there's a problem in trying to solve the problem. The issue was, well, you make your best car. If you don't put fuel in it, it's not going to work. And then you say, oh, I'm going to buy a new one. Well, I hear you. I think it's similar situation over here. We have pretty strong existing systems. And because of the various pressures that we are seeing, and then again, because of lack of investment and the timing, there's no surprise what we are seeing at this time. And then if we actually put the resources into prevention, resources into early intervention, nobody will be at the emergency room. And that's what I say in the intensive care unit. In my other job is that my job is to figure out how to make the intensive care unit empty. Because if we take care of healthcare in an early manner, nobody would be in the intensive care unit. And I don't see any other questions from any of the committee members. What I can do is I can just say thank you to each and every one of you. I can tell you I have benefited enormous amount from your perspective, your conversation. This is something that, and that this is, well, when I'm just applauding you and thanking you, they stop the recording. So there's no record that I'm appreciating. But I cannot thank each and every one of you for your time. That's a most important resource, and your wisdom, which is the next most important resource. Well, you can be either one. But I have learned a lot, and I know people have learned a lot. This is going to help us and our fellow legislators make better choices, and then also recognizing that literally each and every one around this table and on the virtual world, we are one team. We are here to take care of our children. It's going to never be one against the other. We are trying to do the best with the resources that we have, and we may have to work together to increase those resources in some of the situations. And clearly this is one of those times, so that we intervene now and then hopefully we will be able to address these things. So thank you so much for each and every one of you for your time, and thank you for my co-chair, and you can actually have the final closing word.
You know, Chucking, he gives me the final closing word. I mean, this has been Senator Anwar's baby, and I'd like to actually, in front of all of our colleagues, I'd like to thank you for putting this together. It was a tremendous amount of people that you put together in a very short amount of time. But what you did here today is actually, he's very right. It's going to provide a better roadmap for what we can do in the upcoming session. And it just shows your intense commitment to kids. And I don't think I could have asked for a better co-chair. And I think I need to say that publicly more often. It's absolutely true. I appreciate you. And this has been an amazing day. So thank you, sir. And thank you to all of you.